everyone. Just a quick reminder, we're going to get started closer to 9:10. We just filled in a few meet and greet time, but this morning we know the folks are coming in person. There's some folks may be aware, a little extra traffic, especially if you're coming from the south, a little slushy out there. So for those online, we'll get started and closer to that 9:10. We'll get started here in just a minute, so people know we'll get started here shortly.
Long drive for you.
Oh, it's all right. Yeah, it's really cool. They sort of, and everybody up there, it's like not very much,
Yeah.
sort of balance.
That was Robert Carroll, from Linden College
I
there.
just want to confirm.
Oh, yeah.
Hear us. No, verbally.
Yeah, we can hear you.
Great. Thanks, Mark.
We did not have our boat or paddle to get up there.
Understood. Yeah, I'm surprised the number of people here, which we're very grateful for those who made it in. I know it took me a little extra time to get here this morning, on 91, so it is still snowing here, in Hartford, so very exciting. So we'll get started, and kind of, so thanks for those who've come in person and really understand, thought we'd have more people online, but glad to have this conversation. We'll just go through quickly the agenda for today. So just some voting remarks, goals, phase 2 kind of review, which is part 1, and then model structure and key design elements. And then that I'm taking a break. We'll play a little bit. We'll see how the flow is going for the morning and kind of play that break by ear. And if we need to have more time or less time before that, and then we'll talk about key design elements for the kind of payment model structure and have a pretty long discussion we anticipate on that component, and then wrap up discussion next steps. So I think that's pretty much where we'll land for the day. I anticipate we could end before the 3-hour mark, but I always say that, but I feel like I don't say that. Who knows?
Guaranteed. We'll be here.
But we'll see. I'll pass it, I think, over to Mehul for some welcoming, I think, remarks and report.
Sure. I'm looking outside. I think maybe snowed in, so get ready for you may not be able to leave at all. So first I want to say I know the commissioner really wanted to join the meeting. She had some unavoidable conflicts, and if she's able to get out of them, I think she may be dialing in. So if she dials in, we'll take a quick pause, acknowledge when she comes on, and then take it from there. I think today, I know this slide we've put up every time, but I think everyone's sort of aware our primary goal in this group getting together. I think for me, I just want to say today, it seems like we're going to get into a culmination of a lot of the work and feedback and contributions that this group has had, and really dig into our kind of first pass of what a alternative payment model may look like. So just really looking forward to the discussion and your contributions, and already given we've had a lot more folks show up in person than we had anticipated at the beginning. I think that just speaks to the fact that this is going to be a very important discussion. And of course, the folks participating online, appreciate your participation as always. So with that, I think we just get started. Keith?
I think on the next slide, yeah, this is just an overview. Slide 4 is just an overview of where we are. Just recentering. Great, thanks. We spent last year, April to September, we spent some time collecting facts, kind of centering ourselves on what are the challenges, what does the data look like. We then spent the last 6 months on phase 2, which is thinking about the different program design elements. And today we're at the cusp of phase 3. So I think this is an important meeting where we start to talk about like, okay, what are we going to do with that information? In the next slide, the goals for today, we have 3. The first is to briefly, hopefully, take stock of where we are, kind of review really briefly the facts and preliminary input decisions that this group has made. Then number 2, for us to play back what we've heard with a semi-concrete structure. I'm not going to call it a proposal, but it's a structure for how this might work. And then get feedback from you all and talk about next steps. So a little bit of review, our playing back, and then talking about it. And that's basically the goal for today. And without further ado, let's jump in.
So I've noted really just phase 2. At this point, you've all heard it said, but I think it's always helpful to reorient ourselves to what's been discussed to date. And so we'll do that. I won't spend maybe as much time as I have previously, just because I think we've seen this quite a bit. But just as a reminder, the three real pieces of design we talked about care delivery, we talked about performance measurement, and we talked about payment models. And we did that sequentially. And we kind of landed on our top 5 core domains of care delivery, the redesign, chronic condition, BH and targeted care management, accessibility, HRSN screen and community supports, data infrastructure and data sharing, based care. Talked about how we're going to measure that kind of at a very high level. So maybe initial proposal for those measures, as well as how we might define success for each of those. And then we discussed the payment model components, including the base payment and the payment on top of the base payment. So again, we'll jump a little bit more. And then in the last meeting, you'll recall, we did also discuss our cross-cutting equity strategy and some of the things that we looped in throughout to make sure we're bringing that in. So go to the next slide. So this is the payment model feedback. This was again from the January 18th and February 8th meeting. And we've discussed this previously, but just as a reminder, kind of summarizing some of it, I'll just really highlight the is that the overall of the design of the payment model should consider building in flexibility for broad-based participation, tiers, tracks, or glide path, ensure FQHCs are able to participate, align with other payer models, ensure provider participation and patient choice, provide data tools and technical assistance. On preferences for, as we talked about the base payment model, we have some mixed feedback as we discussed previously. Some really folks advocated for maintaining fee-for-service structure. Others really spoke to the value of a population-based payment, also PMPM, just using those interchangeably per member per month payment. And then some highlighted the benefit of really that hybrid between fee-for-service and the opportunity for PMPM or population-based payment. And so that tension was very notable. And so you'll see that later on in our proposal where that comes in. On the next slide, talked about the performance-based model design. And again, talked about that some larger providers have more experience in this space and are more ready to jump in for risk arrangements and based payment arrangements. While smaller providers may have less experience and need a different structure to be able to participate. About driving improvement in quality of care using incentives to do that, driving improvements in access, recognizing that having a primary source of care is really foundational to driving quality and prevention, and incentivize a focus on prevention and thinking about how we can offset those disincentives that were traditionally baked into structures so that we can really get a focus on improving people's health and not being disincentivized to do that. We talked about incorporating risk adjustment and really both social as well as clinical risk adjustment. And we talked about setting the stage for financing and accountability that enables the upstream prevention and investing in community capacity, which we definitely heard from you, is the need to invest in community support and trying to build that in. Ben, go for it.
So this, I think, is going to be something that comes back later too. But if I could, I might just want to put a little bit of a nuance around that first bullet. I think that there are probably large providers who don't have experience with VBP and probably some smaller providers who do. I think where the size of the provider matters is how much risk they can take on. Because as everyone knows, you can have an outlier case, and if you have a smaller pool of cases, that can have a big impact. So I might nuance that, like, there is a large small thing that we need to think about, but it may not have anything to do with whether they have experience or not.
Definitely appreciate that.
And I,
To get some of the nuance. Go ahead, Ellen.
yeah, as while we're doing nuances, this isn't all about provider readiness. This is also about what's right for consumers and patients. And actually that should be the first thing. And at least my feeling of wanting a good blend, a solid blend, a robust blend of fee-for-service with per member per month is not about provider readiness to take on provider risk. I obviously saw some providers because they took on risk they couldn't handle, but it's also about providing care, incentives for underservice and cherry picking and those other things. So it's not all about the providers.
Appreciate that. And I think we tried to hopefully ground ourselves in that as we made these decisions and appreciate the nuances you all are providing. So I think we go to the next slide, which we talked about the kind of cross-cutting equity strategy review, which we've already discussed in detail, and how in each of these domains, there really were considerations for how we would build this in throughout. So in care delivery, we talked about integration of CHWs, HRSN screening, the use of HRSN's SDOH data, requirements and competencies, including individuals with disabilities or ADA, adherence to national standards for class, and then talked about performance measurement and making sure that we're thinking about the collection of RELD data and performance measured segmentation based off of that. And then using patient-reported experience measures when possible, use of process measures related to screening and addressing HRSN needs. And we talked about payment model as well, same thing. We're really using that REL data to help inform in segmenting on population segmented measures, base payment that provides care delivery flexibility and funding support, care delivery and performance measurement, and using the medical and social risk adjustment that accounts for patient needs, which we discussed in the prior one that and thinking about that multi-track program that enables job-based provider participation, as well as options for then members to have access to different providers and different tracks. We can go to the next slide. And then we got feedback from all of you on this. This is distilled down from that March 7th meeting. I'll just spend a moment walking through this since this is new. Members generally agree that the strategy components were a good starting point, but they're highlighting areas that could be enhanced or built upon. Practice should be held down for existing standards. So things like language access, disability accommodation. We're advised to leverage evidence-based practices and build on existing programs to the greatest extent possible. And then emphasize the need to appropriately support and fund CHW's community health workers. Noted also the importance of patient choice in HRSN providers, and that participation of smaller agencies may have more shared culture, language, neighborhood, race, ethnicity, et cetera, enabling better choice and delivery of service. And then several people emphasized the need for educating providers and patients on why REL data collection is very important and how we use that to further equity initiatives moving forward.
On the last
Take a moment.
point
Yeah,
there,
go ahead.
just educating providers and patients, even on all health-related social needs, as well as REL data. That's something we've been talking about internally and that we heard from our Family Advisory Council as well.
Alice?
Yeah, I just wanted to maybe add just a point on the one around the members, the patient choice of HRSN providers. They are often folks who do not bill or do not have systems fee for service, and they're often grant funded and really dependent and reliable on philanthropy. So it's one thing to have a system to access these providers, but there's no real infrastructure support for these providers going forward. So that's just a point. I don't know how you might want to add that in there.
Thanks, Alice. All right, I think we can appreciate the feedback along the way. We've also heard about the need for DSS supports. So we're just going to highlight some of those, that how can DSS provide support to practices to achieve primary care goals. So you'll see here that some of these include pursuing strategies to get members attributed to a primary care provider, doctor, recognize the importance of regulatory care, increase availability of timely actionable data, provide technical assistance to providers, acknowledging different provider starting points. And Ben, to your point about some smaller providers may be more ready for EP arrangements, some larger, maybe less. Developing trainings, materials, and technical assistance related to health equity, data collection, interventions, and participate in broader statewide efforts underway to invest in community supports. Back to Alice, you're the need for that, and I know that was an important discussion at our last meeting.
A quick question.
Yes.
The first point that you had there, attribution, like I'm sure everyone in this room knows how challenging attribution is. So I think it's important to have that in there in terms of making sure they're attributed, but also making sure that they're actually seeing the provider that they're attributed to. Because we send out multiple lists that we get from health plans, including the Husky program, that have patients attributed to us that our physicians have literally never seen. So I think that's like a nuance of attribution, that it's not just are you attributed, but it's are you really attributed to the right person?
100%.
Yeah, and that makes sense. I think the intention behind the bullet that we can reflect language was for members who don't really have a primary care home. there are things that we can do to help, not perfect tools, but there are things that we can do to help make it easier for them to find one. And I think that's sort of what we had in the first bullet. Just this slide is new, but I do think this content has come up throughout. Are there things that are missing? Obviously, it depends a little bit on where we land, but
Yeah.
are there macro things that are missing from the slide that we haven't?
So I appreciate the call out of participating in broader statewide efforts. I think one of the things we talked about early on and has been our experience is something around streamlining access to services within DSS's existing portfolio for things that are related to health-related social needs. So whether it's SNAP, WIC, VEO, like all of those things that you're already providing, there's a lot of hoops to jump through. And so, you know, how do we make those less cumbersome for the community health workers, for the members, for our care coordinators, and what's that infrastructure? Because I think there's what's within your control in DSS and what's going to require partnership elsewhere.
Can you, I'm sorry, I just wanted to see if you could expand on like what some of those hoops might be, because that's something we're thinking strategically about and how to streamline processes.
Sure. So if a CHW is working with a member to fill out applications for some of those services, which is something that they do quite a bit, it's, you know, what are the accesses to systems and tools and, you know, reminders that like if they're acting on the member's behalf, where they can do things on behalf of the member, where right now the member has to do a lot of that work, or they have to physically go to DSS to complete some of those things. So if we're looking at the CHWs as being extensions of or partners with the DSS teams, we don't want to duplicate or, you know, overlap in services, but we do want to make it very easy for the CHWs to help the members access the benefits for which they're entitled to through the DSS programs.
Mark and then Larry. Mark, did you have your hand up?
Yeah, so,
Yeah.
thanks. What's meant by the participate in broader statewide efforts underway to invest in community supports?
I think it's mostly that there are interests or discussions ongoing about kind of within between now I'm blanking on not OHS Hannah you're on, but with our State Comptroller's Office. Thank you. Just in terms of and there's some very early conversations about what additional funding could look like for additional dollars that might flow to community organizations. There's nothing that's actually, I wouldn't say there's anything manifest that is leading to that happening, but there's definitely interest in ongoing conversations about it.
I'll also add, there's also the Interagency Council on Homelessness, which DSS, which is just launching, but we're participants in that. There's also a collaborative we're doing with NASHP on housing related supports.
Yeah, like, so like the CAN system, some of those things create like, and I'm happy to get some of our, you know, staff together to provide input, but those are some of the things that we've heard feedback.
Okay, yeah, I'd love to maybe have a sidebar.
What's conspicuously absent here, and I know that you can't be advocating for something that the governor hasn't budgeted. Make sure.
Feed up so they can hear you.
Sure, thank you. So what's conspicuously absent, especially because it's been a point of emphasis in this group, is the importance of covering HRSN services under Medicaid. And even though nothing that the group you record as the group here, you know, signaling equates to an appropriation from the legislature or governor's support, I think in our view, those capacity constraints are so insurmountable today in community supports to not have Medicaid coverage for HRSN services squarely on that list. And then, you know, you might have to say, well, that's something we can't deliver on, but it seems to me it's essential.
Hear that?
And question or comment, as opposed to a sidebar, you know, some of us would like to be a part of that conversation.
Yes.
Okay, so maybe.
Yeah, so if there's a, if you're
I'm happy to set
looking at a
something up.
strategy, I think, yes, some of us would love
Yeah,
to.
as part of the follow-up,
Mhm.
whoever's interested in participating in that conversation, I'm happy to work with.
Larry and then Alice.
So I
I'd
wanted to
love to.
address what's made about attribution.
I'm Larry McGraw. I'm the Chief Medical Officer at CHN, and we manage the attribution process for the Husky membership. I'm sorry, I don't know what practice you're from.
I'm from Connecticut Children's, the Care Network.
Okay, so so the way it works, which is very different than in the commercial world, is that it's not assigned based on geography. It happens after we receive a claim from a provider on your roster for a primary care service. So if you have a question about why somebody's being assigned to you, I recommend that you work with your practice transformation specialist to identify what claim triggered that activity.
That's exactly what we do.
Mhm.
With the Husky program. It's not quite so simple with that. Like we have 60-year-olds that are attributed to us. Where I guarantee we're not taking care of them.
Well, you know, we also get 70-year-old pregnant women, right? When you're
Right.
dealing with a data set for 1 million people, there are data errors that occur. So I think it's important to just keep on plugging away at correcting those mistakes.
And Alice, I'll get to you just to say additionally related to getting those unattributed or people that aren't engaged in care, recently we've been engaging with the CHN team to expand a CHW workforce to help identify unattributed members and actually try to get them connected to care as part of that work. So that's
great.
a newer effort in the last 2 years or so. Yeah, that's still kind of getting ramped up.
Yeah.
Alice?
Yeah, we're currently working on this integrated care for kids where we're tiering individuals and then meeting with them and doing a needs conversation. So it's quite time consuming, but it's also really revealing, and it helps augment the AI data, the data process. But the thing that's missing from here, and the thing that after all of our experience in care coordination, community health worker, is there's no line or talk about flex funds, which is a DCF usable dollar amount that's highly monitored, but very important to be able to deliver those little things that the families need, that the individuals need, that they don't have the money to be able to get over the hump. And so I know that Medicaid and Medicare is moving towards social determinant dollars for things like food, but having flex funds is a really critical element, and there's a lot to learn from what DCF has done over the years. Thank you.
Thanks, Alice. I'll just flag that we did not plant Alice or ask her to say that, but we review the materials because there is a flexible funds component that you will all be seeing very shortly. So I think that may be a good segue to starting to talk about the payment model structure. Seeing other hands up. So, and Alice, you can feel free to chime in again once we through that and provide your feedback on if we're hitting what you were saying. So kind of one of the goals of this payment model structure that's informed by the feedback is really just to put something together at a high level that we could get all of your feedback on, that we've put together as a straw proposal here. And so we're looking for, again, kind of directional feedback on that as we wrap up phase 2 of the work. So we're going to review the design principles, talk about the high level payment model structure, and then the key design elements, and then really collect feedback from all of you to help refine some of that today.
But maybe one thing I'll say, and maybe we'll get to it later, if so, I'll just talk through it now. That maybe elephant in the room isn't quite the right thing, but a large animal in the room is around funding and money. And just to lay out kind of where we're going to go from this. So we're going to take your feedback. We're going to think about what this could look like. Then there's, a budget discussion that we will all have over the summer and the fall, thinking about the administration and all of its priorities, et cetera. I want to bring you all into the tent just a little bit, which I know you know all that, but because we're going to have this conversation, not fully knowing what additional money, if any, the administration wants to invest in this, and it partly depends on what we bring to them. It's just a little bit of a back and forth. I just wanted to bring that up because I think it's important for us all to think about trade-offs as we get into this conversation, that regardless of the amount of money, whether it's no additional money or lots of additional money, there are more things that we all would like to do together than we're going to have available to us. And I feel if you think of a funnel where we've been gathering lots of input and feedback, and that's terrific. Now we're a little bit in the state where we're going to need to think about those choices and trade-offs. We don't fully know our budget, but I wanted to just plant that because I think we're about to transition to this part of the discussion. If that was on the next slide, forgive me, but
It's fine. It's good. I just want to go to it because it's the.
Sure, sorry, okay, great.
But I think Guy teed it up nicely that there's state constraints and also thinking about the federal constraints as well. Just comment that we also need to consider what CMS is going to be able to approve depending on which authorities we work through. And so those are really the two kind of constraints that we wanted to highlight as part of this, that Guy did a really nice job, because that's probably one of the major ones that'll be upcoming in the near future is the budgetary one that we'll have to think about. Ellen.
Yeah, I mean, those decisions, I totally get it. It's been my life for most of my life. However, I think when you're looking at that funnel, think about things that you can test and will actually improve access and quality and things that will end up with patients getting better outcomes, not just who's lobbying you the most. And it's also understandably not just your decision. The legislature also has a role in the budget. And they have priorities as well. And they, by definition, they have to listen to their voter. So I think I can see this group helping you. We're not going to call it lobbying about where to put that money and what makes sense. But I think definitely testing when possible, because we throw a lot of money into things. And as Jim rightly said, once you throw money in, it creates something, you can't get rid of it. It's there forever.
It's really good. I'm really glad you brought that up. A little bit of a side note. DSS recently applied for and got a $2.1 million grant from Arnold Ventures to ramp up our analytics team to be able to do exactly the type of testing that you're describing. Not for the interventions themselves, but for the data folks and engineers to measure what's working and what's not. So Ellen, I very much agree that I would love, there's some things that are very hard to test, but there's some interventions that, for example, on the getting more members connected to primary care providers, you could imagine, it might be 3 different strategies for us to do that. We could send a letter, which is inexpensive. We could have a CHW, which is more expensive. We could do nothing. We could, we could, test which one incrementally leads to more members getting matched to primary care doctors. I know that's a small example, Ellen, but I very much, I'm on the same wavelength of the testing.
And also look at the literature, because some of those tests have been done in other places and not been formed.
Agreed.
It's one-off money from the Arnolds?
It's a one-time grant. Yeah.
One-time grant, okay. But it's internal, or are you hiring consultants?
We're gonna do it through Yale, and it's gonna be people that we're planning to do this not by paying a lot of money to McKinsey or someone, as great as they are. We're gonna try to hire people at Yale to help us.
Probably a good idea. Arkansas paid like $30 million a year for McKinsey.
Yeah.
Congratulations on the Arnold Ventures. That's terrific. I guess I'm wondering from a funding perspective, is that a conversation the state has sort of on its own, or is that something that involves folks who could contribute to the solution? So the hospitals have formulated a framework that would provide $100 to $300 million a year in new funds for hospital and community partnerships with primary care to substantially enhance the ability to invest in community solutions. And those community solutions encompass all of what it takes to make it possible for primary care to achieve its goals. So we basically laid out options for how that could be done, not unlike what other states have done with 1115 waivers, like Massachusetts. They have creative ways to generate the state share to enable a substantially greater transformation on a substantially greater scale. That's inclusive of some of the community partners that Angela and Stephanie and Reverend Anderson. So I guess, where does that fit? So you've got a potential proposal to substantially enhance the resources available to enable success of health equity, which is hard to do with just tinkering around the edge of the funding.
I think I view them, there are 2 important conversations. There's the what do we want to do and how do we want to pay for it? And we're gonna need to operate them in parallel. Ideally we would have the budget constraint and then figure out the what, but the reality is we need to have both conversations in parallel. So I think that's how I'd like to do that.
I think the next step, you'll see where we flagged where we have budget, where the constraints will come into play. And so you'll see that there's pieces of this that are really dependent upon that budgetary and appropriations process as we kind of move through this. So this will come back up as like, okay, here's things that, and again, this is kind of, like, to your point, this is maybe outside of a little bit of, it includes primary care, but also includes other things outside the scope of this conversation. Obviously very related, as we all know, including access to the health-related social needs interventions. But today it's really focused on the primary care component of it, knowing what we can realistically probably fit into this box to then move into a budgetary conversation as a next step. So I think going to the next, or maybe the prior slide, where we kind of go to talk a little bit about some of the design principles that we've tried to pull in from the conversations that we've been having. And then that informs the next phase of actually what this payment model looks like. So these design principles, we'll just walk through them. Important, again, these are all pulled in from the conversations we've been having. One is building in flexibility for broad-based participation, using tiers, tracks, or a glide path that recognizes different starting points, gives providers options and the flexibility to choose which path is right fit, align with other payer models to greatest extent possible, recognizing the distinct characteristics and needs of the Medicaid population, a limit model complexity, administrative burden to ensure provider participation and patient choice, recognize the respective strengths of fee-for-service and population-based PM per month, and assess which payment model is the best fit for addressing opportunities on a service-specific basis, provide predictability and flexibility to enable practices to advance care transformation goals, incorporate risk adjustment, explore methods that recognize the needs that are more prevalent in the Medicaid population, and establish a quality measurement program that will drive performance, enable ongoing monitoring, quality, equity, access, recognizing both performance and improvement at the practice level. So these you'll see weaved in throughout the next phase of the conversation. We kind of walk through, some of the design straw decisions and where these principles align with that. So we'll be looking for your feedback to see if we seem to match them correctly, if there's other things that we need to be considering. So at the highest level, we can go to, I think the next slide is that, and I'll just orient you to this slide. This is kind of a very, very high level payment model structure. The next slide also dives into it a bit. At the bottom here, you'll see key terms that are helpful. And so I think, Alice, I'll just call out the flexible funds, non-visit functions that you had mentioned before. We're calling that out here. On this kind of 2x2 at the top, you'll see small provider track, large provider track. Underneath that, you're calling out that FQHCs would be eligible to participate in both of these depending on size, capacity, that would need to customize it to fit the FQHC specific needs, acknowledging the impact and design implications based off of some of the federal PPS requirements.
Brad,
Underneath that,
I'm sorry, since you called it out, I just wanted, there's a couple definitions of flex funds, and what I'm really mentioning is flexible cash assistance for folks, and I'm not sure if you're going, what definition you're using. It seems like it might be a payment to the provider rather than a payment made to for a person to be able to put a down payment on a house or a battery for their car. So I just wanted to get clarity on that.
Yeah, and the definition on here is, it's probably more a per member per month amount. I'll just read it, layered on top of another form of payment. Usually it could be fee-for-service, could be a population-based payment, and that providers typically receive this to help manage patient care and support the coordination of other providers. So I think a little different than the term you're using, Alice, just acknowledging, again, some of the limitations that, going back to that prior slide where we have to think about federal limitations as well and how we're using some of these dollars in it. But we'll be getting feedback at the end. So Alice, I think, please feel free to circle back to this.
Yeah, I'll send you a link to Massachusetts and how they've defined it. Thank you.
Hold on one second. I'm not sure why the recording stopped. That was strange. Just a second here. Make sure that we are. Yes. while we're doing that, but did you mind just walking through this, the other piece, and I'll try to get us back sharing so that we have it up.
I think Mark had a comment.
Oh, Mark, go ahead.
I can do it after you walk through. Are you on another slide or you're walking through?
Well, yeah, we have this one just to highlight, and then the next slide goes into a little bit more detail.
There's something about this slide that I just want to comment on. So I think in previous conversations, we talked about having options that are tuned to the capabilities of the practice. And the categorical small provider, large provider attachment to two options didn't seem to us to be consistent with the idea that some smaller providers might have a value-based experience that allows them to choose a particular pathway. A large provider may have no experience that doesn't allow them to do that. And so the large and small provider distinction didn't seem to be the most necessarily indicative of somebody's preparedness to take on what are the model. And in fact, it's our preference that there be an ability to choose among models, and that if there's a model that has steeper expectations, that maybe it has better incentives attached to it. And so you could choose to take advantage of those better incentives. So rather than a mandatory sort of you are X, you get tracked into Y, something that is a menu of options, not unlike what MCO Reach did, where the opportunities are more attractive, but maybe also the accountability is greater.
Point out at the bottom, and I didn't flag this, and it looks like we are streaming, just away. I'm not sure what that message was that said we weren't, but it looks like we're still streaming. Is that this is really kind of initial. We do imagine that we would need to have additional tiers and or glide paths within each of these to help kind of expand that with the options for people to kind of have some choice within that. I understand, I think what you're saying, Mark, is like you're worried about the size piece maybe not being as relevant. But I think there's probably will need to be a lot more that goes into this than just small, large, but as a starting point. Go ahead. And then we'll get to
That's helpful. The second part of my question is, what quality gate shared savings risk mean? We have, having spent a lot of time deliberating amongst the hospitals. We don't believe that a secure model that's specific to primary care is right. And I didn't see that really as a recommendation of the committee, but that there, because the models across the country while some have advanced quality and some have advanced cost and few have advanced both, there's now over a decade of history that shows primary care has limited ability to influence the outcomes. Now the Iora Health said it designed these practices to focus on a particularly high need complex population, and they've been successful. But as an overall model, what we've been proposing, and this suggests otherwise, and that's why I think it's important to sort of take a pause. This suggests shared savings risk suggests that the primary care practice is accountable for total cost of care for attributed patients. And simply stated, we believe primary care should share in should have incentives and should share in successes, but that there should be a structure that encompasses a broader set of system actors, such as hospitals and community partners, around accountability for total cost.
I'll just note that I think this isn't necessarily saying that it should be a total cost of care model. It's just saying that it should be that this is on the playing field in terms of quality gated shared savings risk, but what goes into that bucket is not being defined in this place. It's a broad, but I understand kind of your concern of a total cost of care. I wouldn't say that's off the table either. I'm just saying that this is a broad framework which could be molded to fit different things and have different things in that bucket. Understanding some of what you just brought up, and Jim, I don't know if you want to.
Yeah, I think Mark probably stated, but I was going to go down a similar path here that, when we shift, it sounds like these two models are related, but as soon as you enter into a total cost of care savings or some segment of that, to expect primary care to deliver that becomes unrealistic. When you look at and I just break these down into four big buckets of what you're trying to manage when you've got a global risk is you've got the sick care. That involves hospitals and care management and specialists. You've got chronic disease management, also very much anchored more to specialists than primary care's ability to manage that. And then you get the rising risk and the wellness pieces. So though primary care has a piece of it, it fundamentally shifts. And if we're trying to figure out here with what we're focused on is how do we incentivize primary care to get to capabilities that would impact and layer into all of that? That's very different because as soon as you enter into global risk, the focus has to shift because you're just not going to get there. Primary care cannot, especially in our state, cannot influence most of the stuff that's driving a lot of the high cost right now.
Holly and then Joe. And then
Joe.
It's a great conversation. I just want to raise a couple points for the record. I think, so let's look at some of the objective evidence we have about different performance. This is maybe a little more academic, but let's look at MSSP, for example. So when you look at historical performance, I just want to point out for the record that when you look at hospital affiliated and hospital not affiliated groups, that there has traditionally been an as good or better performance of those groups in the MSSP over the years. So I just want to point out that I agree with what you're both saying, that we need health systems and hospitals to be part and even broader scope of those who provide services to be involved in these efforts. I'm not sure it's fully accurate to say that primary care, independent groups, other actors in the system can effectively influence cost in a certain way. And so I think it's more an open question than a concluded fact that that's the situation. And again, not that as someone who manages an organization that's just physicians, we don't want partnerships and we don't think that they're part of the way forward. But I just think there's a little more nuance to that point.
So Joe, even in Medicare, I get that the non-hospital affiliated groups have done a better job of driving savings. But when you think about significant movement of the needle on A1C control or hypertension control, I don't know that the evidence supports marked improvement.
Yeah, so Joe, the only other problem, I have trouble with MSSP in general, because I agree with you. But a lot of MSSP comes to, you know, what's your budget number and configuring your participation around what your cost benchmark is, and not so much dramatic change in the care delivery change that drives down lower utilization a lot of times. So MSSP is a complicated sort of program for all those reasons. That's a little hard to say you're actually transforming practices that drive down utilization and improvement in outcomes all the time, because there's so much, a little bit of Moneyball going on, but that happens a lot in MSSP. It's just simpler from an attribution perspective to put a primary physician group together than trying to do that with hospital systems. You can't do the math. So I think there's information there, but it's not apples and apples.
I think both are true. I mean, having been in an organization, obviously where we filled it on MSSP, there's a lot that the primary care physicians are doing, but it requires so much more in terms of the hospital partnerships and having a specialty network and making sure access is there. So the incentive for everyone to work together is, you know, that's mom and apple pie. We all would want that. I think the challenge is when you start competing for those dollars, right? And it shouldn't just be primary care is responsible for everything, but we have to recognize that more money has to go in the pot, because if we're including now hospitals and specialists and community workers and all of these organizations in it, it simply means there has to be more. Otherwise, there'll be no return. It won't be a sustainable program.
Holly and then Ellen, did you want to
I
add?
just want to ask a clarifying
Yeah.
question and hear you on the nuance. I think a lot of shared savings programs have a lot of Moneyball. One mark of a good system is that we have less Moneyball and more practice transformation. I just want to make sure I understood the fact that you were saying with all the appropriate caveats. So you're saying empirically, if you look at the MSSP program, you compare practices which are non-hospital led versus hospital led, and you look at all the caveats to measure performance under the MSSP program, the results have been similar across there. I just want to
Not better for the.
Thanks.
Are those multi-specialty groups though?
I would suspect it's a mix. I don't know if they broke it down between primary care only, multi-specialty.
I don't think they did, but it's a healthcare's article.
Yeah, I was gonna say if
Yeah, we can share. That's
all the MSSP program, there's a lot going on there, a lot of caveats. So I think it's helpful whenever we have a data point, it's helpful.
Holly and then
Yeah, I don't know. I feel like we've had a bit of a, of a mixed experience, when we've Northeast Medical Group has done well in our ACO program. When we married the resources that we're managing the Medicaid PCMH program, which were at the time, 3 years ago, in the lower quadrant for quality, with the same infrastructure we were using for our MSSP, we moved to the top tier of quality because we were using a lot of the same workflows and reinforcing that that was how we were going to do care. But if you look at the return on all of that work in the PCMH program that we were in, 50 practices, about, 22,000 attributed lives. MSSP that we have ACO is roughly the same amount of attribution. So to move from quadrant 0 to quadrant or 4 to 1, it was 50 cents per member per month. And we got just shy of $130,000. In the ACO, we got a couple of million. So the return and what I can do with 130,000 is way different. But I feel like we've proven that the compounding and putting these resources together and aligning the program has led to better outcomes for the members that we're serving. And it's also less complicated for our providers because we're all working on diabetes control together. We're all working on hypertension together, and they're seeing how we're looking at performance and lining up the measures across the programs. So, but I also just want to point out, we put a lot of effort into the existing program, and in only the last 2 years have we generated a quality bonus. And, it was 80,000 and 130,000 for a lot of work. So, the level of effort that it requires funding different things to get to the different outcomes. So I just want to make sure that, when we're thinking about the structure here, and I know there are going to be funding challenges, that's the level of difference that we're seeing when we're able to get multiple millions of dollars and reinvest it back into infrastructure versus, a very small amount.
Holly, have you done the analysis though of what you get in the enhanced fee for service for PCMH versus?
But that goes to the providers for, then that gets them up to a base level of primary care payment that we think is adequate. So, that's the other piece of we have to make sure the base fee for service is adequate. And so those are going to provider reimbursements, which if they were not there would be much lower than Medicare. So
Larry, with the primary care bump and the PCMH bump, you're at about 100% Medicare.
What is the baseline reimbursement under the ACA? I thought we were starting at 90 and then
An analysis I can share with you.
said they get more.
It may be
Me
wrong,
too.
so it'd be good to do a cross check.
the base payment is whatever is under the ACA, which I thought was 90% of Medicare. And then the fee for service enhancement is 24% on primary care services.
it's on Medicare from what, 2014 too? No.
And it might be on, I don't know if you know those off the top of your head, but I know we looked.
So Medicaid is on the 2014 Medicare fee schedule,
Yeah.
well, which would be severely, that would be.
So and these, so the fee for service bump gets us somewhat to where we would think would be. But that also hasn't adjusted. Also, I looked back at the last 3 years, the PMPM for Medicaid, the best you can do is 50 cents PMPM, and it stayed that same way for the last 3 years. So that's a very little, compared to any of our other, literally any of our other payment programs. And we're talking about a population that we've clearly identified through this work has high social needs, high chronic conditions, and they need the most interventions. And so I think we really have to be honest about what it's going to take to move the needle.
Yeah, I think it's a reasonable, and I just don't want to spend too much time making sure, because I think how much we pay is really, really important. Acknowledging there's limitations of what we're able to do in this conversation, but I think we definitely know that the need is there for the population. There's a high need population. We often are paying underneath what Medicare is paying, even with our additional payments. We know there's need. This conversation won't necessarily, I think probably all of us understand there's a need. I think we can reflect that as we're moving this forward, but also acknowledging how we pay and also how much are both very, very important to this and focusing a little bit more today on how we're doing it than how much, though that how much is, as Guy kind of pointed out earlier, is part of this conversation and will lead to a different follow-up in the very near future. Ellen?
Yeah, I don't know where to start. First of all, back to providers deciding. That's great, and I get that. I mean, you gotta keep your practice going and pay everybody and keep the lights on, but we need to give patients a choice as well. People ought to be able to opt out of this the way they do PCMH plus. There should be no reason why people are concerned, and they are, that their provider has any reason not to give them the best care. And just offering that to them makes that very clear. So that should be built in. I agree completely about needing resources and care, and I get that, but I also understand giving PCPs more control within those systems. I hear it all the time from primary care. Like, once they're gone, they're gone. I have no control within this health system. I'm just not in a place that I'm not at the top. I don't make those decisions. So if there's a way to get to both of those, I think using money to try to get there is a really bad way to do it, because there's so many thousands of ways to game it. I mean, we could spend hours and probably not think of all of them. If we want somebody to do something, pay them to do that or expect that from the program. And then just pay them what they need to make it right from the ground up, figure out what a decent rate is and pay them. There was something else. Oh, and being underpaid. Yeah, we get that. We totally get that, working in little community organizations as advocates. And sometimes you do the right thing because you're being paid well by others, or you can just make it work. But there was something else that's gone through my head.
Mark has a question in the chat.
Or do you want to chime in? I'm not sure I saw that.
Yeah, no, I just, this collides with the PCMH plus funding. I don't think it's in the budget or planned for January 1st, 2025, sort of ends. And so what's the department's thinking on that? Is this 11-15 plan going to be in place at that time, or are we sort of in limbo? And certainly concur with the conversation earlier about the investments that we've all put into this program, and don't want to lose sight of that in this discussion.
Thanks, Mark. I'll just say in terms of, so appreciate 11-15. I don't think we've just said like which pathway or which way we'd want to go down. So it's on the table probably for how we're thinking about this in terms of whether that's needed, acknowledging there's a lot of complexity. If we do want to pursue an 11-15 in terms of authority pathway and what that entails, I'm not sure that's what we'll need depending on where phase 3 heads. And just to say on PCMH plus, there'll be more to come from DSS in terms of future plans on that. As we talk about this, we are envisioning this as kind of figuring out what we're doing next for PCMH and PCMH plus and what the successor of those existing programs are. We definitely don't have an intention of having a large gap between whatever we're doing currently with what we're launching. So, but we will be having internal conversations to kind of sort out some of those details and appreciate the importance of that.
Yeah, and just to clarify, Mark, and I just to connect the dots with others, Mark and some colleagues and I had a conversation with the commissioner a couple of days ago on a variety of topics, including this one. And Mark, just to clarify, it's not that the money isn't in the budget. I think the commissioner is just reflecting, hey, we have these existing primary care programs. We have this group that's thinking about what's next. What is next will involve reforming or changing what happens today. Like that's what this group is convened to do. And this group and also, you know, the commissioner and the administration is thinking through what that transition plan could look like. So I didn't want people to hear your comment about the budget to think, to misinterpret. I'm just trying to clarify it's kind of status quo until we make a decision about what we want to do. And then the legislature will have its thoughts as well, our partners in the legislature, but I just wanted to clarify that for everyone.
Yeah, I just note that it's April 4th and all of us are planning for our July 1st budget. And so it's, you know, we look forward to those continued conversations.
Appreciate that. Yeah. I think we'll head to the next slide, but it will continue. There'll be we anticipate a lot of conversation on this topic. And so we'll a little bit more into the kind of model structure. This is kind of a more detailed look at thinking about base payment and then incremental payments. On the left-hand side, you'll see kind of that terminology we used previously in terms of like where's the majority of revenue coming for practices, and then the incremental payments underneath. And again, caveating that underneath a small provider track versus large provider track can be multiple kind of tiers within that. Doesn't not calling that out. Again, this is a very high level kind of representation at this point, but thinking about that base payment really of being a combination of fee for service plus population-based payment, or that PMPM, or per member per month amount. And then really that transitioning a portion of the existing kind of fee for service structure to some of that as kind of a base payment model. Obviously needed to figure out what exactly falls on within that, but trying not to obviously increase administrative burden by shifting some of that base payment dollars from fee for service to PMPM or PBP. See your hand up. Go ahead.
Yeah, so I know that the whole deck is sort of structured around this idea of a small provider track and a large provider track. Is there an openness to thinking about a track A and a track B that's not based on size, and there being some ability for providers to opt into the track that makes the most sense to them?
Yeah, again, I think this is our initial proposal, so there's definitely willingness to hear and listen and get feedback. So very much welcome that. And Ellen, I saw your hand up as well.
Yeah, I guess when I saw this, I was surprised. One of the feedbacks that you acknowledged somewhere here it is, that fee for service payment with PMPM for additional capabilities is the best route to harmonizing with other payers. I think it's just the best route for consumers as well. This, when I looked at this, there is PMPM all through it on the it's merged in the small and the base payment. The flexible funds are PMPM. The incremental payments are either a quality performance P4P or a gated shared savings. So I see provider risk in the entire thing, and fee for service becoming almost an afterthought. And that's not certainly the way I read the feedback that you got. And it's certainly not my opinion. This looks like you just put it in different buckets, like we wouldn't notice. It's all per member per month, that it's capitation kind of all through.
That's interesting, because I did not read it that way at all. I read it as underlying fee for service with potential PMPMs smaller, much smaller, not like total cost of care, but for hitting specific quality metrics, like say $1 per member per month, and certain for the administrative things for the investments, like $2 per member per month.
Right up what she just said.
I think that's what the green is. The green is flexible funds not in the Alice Forster way, but flexible funds, meaning covers behavioral health care management or CHW costs, or even some quality improvement activities that are otherwise not lend themselves to fee for service. The base payment is very clearly proposing a partial primary care capitation. And that is taking core services that are provided by physicians and mid-level practitioners for primary care, whether telehealth or in person, and converting those to a partial capitation. And the question in my mind when I saw this, because it did seem to controvert what was discussed in the group, other payers aren't doing that today. And while hospitals are open to that as a sort of downstream evolution, when we talked about it, it didn't square. Like, are you proposing partial capitation of primary care, and why?
I mean, I think so just a couple quick things. One is like, there's not I think Ellen, your point about like, are we saying that there's very little fee for service versus very like a large portion that's a PMPM or capitated payment or population-based payment? This is really that would be up for discussion about like what that actually looks like. And it actually could be different based on tiers or tracks or, so just to say it's not defined what that would look like. I think to the point that you're like, why, and what would welcome others' thoughts, because I think we heard a diverse group of opinion about like the benefits and downside. And we heard on both sides, I think, some folks very strongly said we should just maintain our fee for service structure. Others that there is benefit of having some PMPM and some flexibility with some of that funding, including in some base payment percentage, which again, it provides predictability and it does provide some regular source of income for providers for a base set of services. And Holly, I see your hand up.
Yeah, I think I was imagining, I think the green areas I was very comfortable with and like, you know, very much in support of kind of an upfront PMPM that is predictable based on membership and allows you to make those investments in care coordination and, you know, behavioral health and those sorts of things. I was definitely surprised at the partial cap piece on the base payment. I also did not think that that was our specific, at least, you know, from some of the other medical group representatives. I didn't think we were advocating for a partial cap out of the gate.
Yep, definitely. I mean, I think we definitely heard.
Weird, I'm agreeing with hospice. Stop calling it weird.
Great. Any other thoughts or comments on this? We'll definitely have more time to talk about it, but just wanted to.
And I guess also, I think it's also going back to that because what we also talked about, I thought was the base fee for service needs to be reinforced and also put on a schedule of being updated, which it has not been. So I think that was also the pieces like shore up the underlying mechanism for fee for service, ensure that's on, you know, a trajectory, and then add on those green
components to drive the overall performance. I just,
But I'm just gonna say that some of that comes to how much and how we structure our payment, which, you know, we are undergoing a rate study as well and looking at our rates systematically. And we're in phase 2, which will be due to the legislature in January. Is that right? And so there's definitely a interest in looking at the how much we're paying and how we update those rates. And you may want to say something else before we, if you want to add anything else to that.
No, just to, and I said this publicly when we testified, our fee for service rate structure is a mess across the board. It's the words I used. I know this group is focusing on primary care. On the specialist side, many of our rates were paying 57.5% of Medicare 2007 rates. 2007 rates. And with the tens of thousands of fee elements of the fee schedule, some have been updated, some have not. It is really a mess. So we are looking at every single rate. We're comparing it to Medicare. We're comparing it to other states. I will say, and this is probably not gonna be a popular thing to say in this room on primary care. I'm just gonna state it. Like with the evidence that we have so far relative to Medicare and relative to other states, primary care is less far behind than many other elements of the fee schedule. That's not making a normative statement, or that's a positive statement. So, and we haven't, as Brett said, we haven't done phase 2 yet, so we're working on it, but, I just wanted to share that with you all. They're all kind of below, the rates across the board for phase 1 are all below the Medicare and below what other states are paying, but there is a huge range of how far below they are.
Okay.
And primary care is not the
Not
furthest.
as, yeah, so I agree with that, what the data shows.
And Ellen, I think Mark had a hand up, and then I know Alice, you as well, so we'll get.
I think one of the things that we've talked about in prior meetings is the importance of access. And obviously fixing the rate structure will be very helpful in bringing additional providers into accepting Medicaid. But I think another thing that will make it easier is simplicity for practices that are not maybe not participating in more advanced payment models. And so having just a straight fee for service structure is very easy for practices to understand when they're thinking about joining. And so I would consider for the base payment, trying to keep that as simple as possible for that access reason that we talked about. I just want to say, I know we're working under a set of financial constraints this year, and we're not expecting anything to change this current legislative session. But my sense from talking to folks in the legislature up to the leadership level is that there is a real openness to adjusting Medicaid rates going into the next longer session. And so I think we should, although you're right, we need to work within the constraints that we have. We should bear in mind that there probably is a lot of momentum for incremental investment going into following year. And this will still be there while we do that.
I think Ellen, Mark, and then Alice.
Yeah, I think, yes, I agree, making fee for service, the base payment model as simple as possible and clear about what it is, because Polly's right, and this is just human nature. You get an increase in your rate, it's just, you're still not at the rate you expected. They don't necessarily equate it with all those things, and I'm sure Northeast Medical Group is doing this, but some are like, that's just a rate increase. We're not gonna do all that other care coordination and all the stuff that is required for patient-centered medical home. They start to erode it and they just start to see it as a rate increase that's still insufficient. It should be really clear and accountable that if you're not doing that, then you don't get this. As opposed to just an increase in the rates. Now, I'm not saying I'm not in favor of both, but not saying I am, but I think we need to be really clear about what we're paying them for and then hold them to it.
So just to play that back. Make sure I'm hearing what you're saying. You were saying, yes, rates matter, access matters for sure. But you're saying if you tie increases to specific things that you want to see, you may get more impact on members than just a straight fee increase.
Rate increase, right? To think that a rate increase is going to get us to do, I mean, you always want value for extra money, you know, in rooms like this, but in rooms like theirs, it's like, finally, you know, that we're losing less on that.
And I will say, like, the access to specialists and fixing the rate structure, I mean, like,
Yes.
let's be clear, like, if what we're talking about is a patient population with a lot of complex comorbidities, the primary care providers need a base of specialists that are willing and interested in accepting Medicaid insurance to provide that care. And we will only be as successful as there are specialists for those conditions that warrant specialist engagement. So I do think it is important, you know, and it is, I just want to acknowledge that, you know, it's positive that this rate structure is underway because that will, you know, assist the primary care providers in getting their patients into the specialist care that they need.
Mark, and then Alice.
So, I wanted to draw a line back to CPC plus, the introduction of CPC plus, which was, I think, during my. And I was at the time a big proponent of CPC plus and partial capitation. They did this hybrid capitation model as part of CPC plus. I was an advocate for moving toward partial or even full primary care capitation, not full capitation for the whole nut. And I was an advocate. I think Ellen might call me a zealot for that, but I would agree. I went around and I talked to countless physicians. I talked to the Academy of Family Physicians, the American College of Physicians, Connecticut chapter pediatricians, and, you know, subgroups of those. And what was interesting was how uninterested folks were in this model. And it makes some intuitive sense. So there is this, you know, at the end of the day, folks want to be able to know that their practice is going to generate enough revenue to cover the costs and then. And so if you have a practice that generates $500,000 a year and it's based on visits with physicians and nurse practitioners and PAs. And so it's 500,000 in visit-based medicine, could be telehealth visit-based medicine. And you convert, say, 50% of that revenue to a partial cap, which was what CPC Plus did, some percentage. To get the other $250,000, you still have to have the same number of visits. It's not like that gives you the flexibility to do things that are not reimbursed fee for service. You have to generate the other 50% exactly in the same way you did before the partial cap. So it defied, you know, when we explained it, it sort of defied logic. Why capitate? Why partially capitate half? So that made an impression on me. Plus, practices are already worried about having to negotiate the fee for service arrangement with the Anthems and the Uniteds and the Aetnas of the world. Now they also have to be worried about whether they're going to be cheated on this, you know, partial cap. Not that payers cheat, but that they'll have two fronts now of negotiation instead of the one front of negotiation, which you can easily calculate. You easily know that this much visit volume based on a panel this size will generate this much, income. So I was, I know I no longer work as a policymaker, and now I'm working on the provider side, and it's not a function of moving to the provider side. It's a function of the fact that when I was in state policy, it became apparent after talking to countless people that this wasn't the problem that needed solving, that there were other problems that needed solving. For example, the additional revenue to cover everything that goes around primary care to make it effective.
I'll just point out that there's a lot of things that is not clarified here. So example, like what services would be included, that would be, right? So do you just say part of it's fee for service? You just split it down and say 50% of it's, you get the same for the same services as PMPM, or 50% fee for service, or do you actually carve out of it that are just PMPM and then other of it is fee for service? So there's a lot of things that are not clarified that I think go into that, Mark, what you're saying, because you're right. If like half of your E&M codes are, if it's the exact same codes and you just take the revenue, sure, you're encouraged to do the same thing. But if you're saying, but there's different ways of doing this. So I just want to clarify that, like,
Oddly, that was what CPC Plus did. So CMMI, the innovators, did it that way.
yeah, Alice and then Polly get back to you. Alice?
I'm trying to follow, so I apologize because I really wanted to follow. I guess for me, just as an explanation, I'm here because of my conviction that behavioral health services can contribute an enormous amount to the health and welfare, through an integrated care model. We all know the head is connected to the body, and that chronic stress often leads to lots of health problems that are, lifelong and chronic, even though they, you don't see them as much in our kids. They grow into adults with high blood pressure and inflammation and diabetes. So
You muted yourself, or maybe someone muted you. Sorry, Alice.
sorry. Someone muted me because they didn't want to hear what I said. No, I'm kidding. But
We want to hear what you have to say, Alice.
But I think that it's really important for us to really remember that behavioral health in some ways is a primary care delivery model. We actually see our kids and families and adults much more and have a greater impact on their life course and what they need and what are the drivers that are helping them. And if you add on primary care to our services, which we have done in different models, we have a higher impact on actually engaging, let's say, the 50-year-old father who hasn't gone to the doctor in a long time and help them navigate all the systems. So I just, we keep in Connecticut these things so separate. And the reality is that they're really need to be integrated, and in a way that when I first started listening to the integrated care movement many, many years ago, as Mark said, I hoped we had gotten there. But right now, we still remain trying to treat the body separate from the head. And until we merge it, not do screening and referral, but actually think about this as a whole person, a whole family, we're going to keep not having as good of health outcomes ultimately. So sorry if it doesn't fit right here, but that's what I think.
Alice, appreciate you elevating the behavioral health importance. Polly, and then.
Yeah, I just, I know we're going to talk about next steps towards the end of the meeting, but one of the things I would just like to reflect on when we say, well, it's not really quite that clear, or, there's still a lot to be worked out, is how when we first got together as a group, there was all this work done previously, and many of us were not a part of that. And it took us many months to all kind of gel around the prior work and the data and get up to speed. And so we're there, like we've all invested probably the better part of a year sitting here together. And I think what you're hearing is like, we really do want to be crisp in the documentation coming out of this phase of work, because depending on how you're planning to connect us to the technical design or how this group will continue to be engaged, it is really like the devil's in the details. And I do just want to be very clear that I think we're advocating for very, as crisp as we can make our work product, so that whoever comes next, the groups that are engaged coming next, don't have to kind of do what we did, which was a lot of go back and kind of get acclimated. And I think we're really interested in accelerating and moving this forward.
So I will definitely talk about that, or I think how we've, at least our proposed next steps really, hopefully make it a relatively seamless process to move this forward. I don't know if I saw any other hands.
I think
Sorry about that, Jim.
And this is just a little bit of a question, just on, as we're talking about, and I know we're putting off what's gonna happen to the fee-for-service payment, Medicaid, certain rates going forward. But if we're offering shared savings, what's your guys' confidence that we can set any kind of benchmarks when we're about to be adjusting rates all over the place in the middle of this program? Because if we're gonna talk, before we go down the path that we should have a shared savings, shared risk, I think that you could try to model it, but I would suggest that if you're gonna significantly change the way we're getting paid, utilization may look very different, and we don't understand that. And so how you're gonna build a benchmark to perform a shared risk model, it's gonna give everybody pause going, we have no idea what this looks like. You've just changed payment significantly.
I think I understand what you're saying, but can you say more?
Yeah, so, and I'll give you a perfect example, just so that you know, because we lived through it. In our MSSP program, they changed the base rate for the rural hospital. It tanked our entire MSSP program by millions of dollars simply because there was a change in rate to certain hospitals. We couldn't control it. It wasn't built into our benchmark. We just went from here to in the tank in a year. If we don't have any historical baseline that we're confident around, trying to build out, because you're going to have shared savings, you're going to have benchmarks and performance and what budget you're working off of. We might not have a budget for several years to really think that through. And before we spend a lot of time offering it as a model, how you're going to execute on it and how you're going to get clarity around what those benchmarks would look like would be really problematic, since we're also entering into a change to where we suspect that the payment rates are going to change. That make sense?
Yes, and I guess I would say, let's just walk through a hypothetical example, just to make sure I'm getting it. And this is not saying this is where we're going, just as an example. Let's say we had some definition on the pay for performance on avoidable hospitalizations, where we think primary care has some role to play in helping avoid avoidable hospitalizations. Yes, of course, if rates are changing both to hospitals and to specialists in the primary care, those changes in rates will hopefully impact access, which then could have a baseline change in avoidable hospitalization. Okay, I get that story. I get the story hypothetically, but I'm not really, that to me would not cause me to say, oh, the rates are gonna change, so let's not pay for the extent to which there's avoidable
Performance we're worried about. It's the shared, it's shared risk, your shared.
Okay.
Yeah.
That's gonna come up.
I started there, so let me make a follow-up example. So let's, instead of the number of avoidable hospitalizations, let's say it was the total cost of those avoidable hospitalizations, something closer to shared savings. I get mechanically, okay, if we paid hospitals 50% more, which we're not gonna do. If we were paid 50% more, of course, the spending on avoidable hospitalizations would increase by 50% or maybe more if there's an increased demand. And I get that the details matter. And if we didn't bake that into the shared savings model, that would be really problematic. Should I read your point as, hey, Guy, if we're going to change rates, we need to make sure that we're changing the benchmarks of shared savings, and that I agree with. If I read your point as, because the rates might change, that makes it sort of impossible to think about this topic more generally, I guess I push back.
No, I think there's ways you can structure incentivizing better outcomes and behavior. That's different than taking some sort of global risk, either you try and contain it or not. If you're just sharing risk, and I would caution, who cares about sharing risk around a sickening activity? You could spend those dollars someplace else in a New York Met. So, you know, we like to, in other words, you could do real well and we get incentive bonus, but on a performance basis in a global risk environment, you're gonna end up as the payer in a hole because we didn't reduce CARES everywhere. We reduced care on this little targeted activity, which is not going to benefit the overall program. So what I'm saying is when we move from performance-based to incentives, very doable. And it doesn't matter. The payment model really shouldn't matter because you can look at just utilization. But when you get into savings risks, that suggests there's got to be a global target budget around that. And when rates change, it's awfully hard to model what the impact is going to look like. So I just don't want to spend a lot of time figuring out a shared savings model without factoring in saying we may have to hold that to see what's going to happen to all these rates and what the payment model is going to look like.
I hear you. I think I respectfully disagree. I hear you. I think what I'm gonna play back is what I'm taking from that is if we're gonna be changing rates, we need to have a process to think about adjustments there. I think you're saying something stronger and I want to say I'm hearing you. I don't think for what it's worth.
You got my point.
Yeah, okay.
I'm done.
But I think he's saying, well, maybe he's not, but.
You're gonna say that. I need help.
But you're changing rates
Yeah.
to try and get changes,
Yeah.
like preventable hospitalizations. So you may have fewer.
Yeah.
So it's not just that they've gone up 50%,
Yeah.
but we have 50% less because primary care is doing a better job of keeping people out of the hospital. How would he model that?
Yeah.
You know, and a lot of what you do in primary care changes things down the road. It doesn't happen in the same quarter. So the timing of,
Yeah.
my head hurts.
Yeah.
Or like
Say-
I
I
can
hear
see
that.
a cardiologist and manage, my multiple comorbid conditions, and
Yeah.
now I'm not landing in the ED and
Yeah.
I'm not landing in the inpatient
Yeah,
bed.
yeah.
So the specialist costs might go up, but
This bucket goes down.
I have no idea.
I'll just say, I think on the next slide, this is part of like what we have to define is and you'll see. Quality gate share is like the cost benchmark and target setting methodology, because these details, as you said, it becomes really important. I think, even to Mark's point, like, okay, is this, if we're even talking about a PMPM, like, is this just a straight split of revenue, or is it certain services that are carved out for that? And what is the implication? And so just to say, there's a lot of the detail that would have to get worked out that have a ton of implications for actually what gets implemented and how its effect on practices. And I know, Joe, you had your hand up, but just to say, these points are really, really important because how you structure it changes the incentives drastically, even within one of these frameworks. The other thing I'll say is like one thing with P Plus, and I know we've had some discussions, is do you have a trend group that is outside of it? We have a large unattributed population. Is that likely to change over time? We're probably, the number of people coming in off. So there's opportunities to think about this in different ways in terms of how do we benchmark it? How do we think about it moving forward? And I think with enough time and expertise and guidance, we actually could come up with something that probably is reasonable to make sure that if there are rate changes, what are the effects of that? What are and I think that, Mark, back to your point, is like, is this total cost of care? And I'm not saying it's not, but I'm also not saying it is. If you define a set of services that we think are modifiable by primary care, what goes into that shared savings bucket is another piece that needs definition and that has to be refined, because the devil's in the details as noted, and these are really important details. Mark and Joe?
Yeah, so thank you for that, Brad. I get the point about the softness of the shared risk, shared savings concept. The reason for this question so we've had a lot of conversations about the problems we're trying to solve in primary care. And we haven't yet had a conversation of what problem in primary care can be solved by looking at a portion of certain element of the service package in primary care population. That might be the case, but by putting it on the page, it looks like we've all endorsed that there is such a thing. I'm happy to have that conversation, not in a detailed way, but just like, Brad, when you're a primary care, practically primary care doc. So you must have some idea, gee, these things I wish were just packaged. That's part of our revenue, because it limits our flexibility, or I want the predictability or whatever. Welcome that conversation. We just haven't had it. So when it's up there on the screen, it looks like we have had a conversation. We haven't, but there is such.
And just to say, this is kind of PSS proposal that we're putting out here, not necessarily, and obviously one of this has to be from what we're taking from the conversation and putting on the page that we're presenting to you. But so just to make sure that's clear. Joe, I saw your hand was up.
Couple comments on a couple of varied topics. One is the only thing I'll say about the most recent topic about the fee schedule issue is almost every value-based program lives in an environment where fee schedules fluctuate over time. I mean, I'm not saying Jim's point is well taken and I don't have a solution, but I do think that we live in a world where fee schedules are changing both in the Medicare Advantage and certainly in the commercial world. And I think that it's just a reality of how some of these things are. It's an anomaly to some extent that the Medicaid fee schedule doesn't change at all. So
About enough, huh?
yeah, correct. So look, we do it in every other program. I think there's a path to solve for that issue, and I think there's a way to manage that. The one issue I want to go back on, because I don't know that was explicitly stated about the different kind of funding sources. I just want to make sure the point, at least this point is made, is that when we think about asking providers to do new services, extra services, to make investments in population health and different services, and there's funding tied to that, I just think we have to be clear about the structure of that funding. And I think for things that require infrastructure investment, ongoing services, that there needs to kind of be a component that is just based upon providing those services and is quote unquote not at performance-based risk, so to say. I'm not talking about more complex kind of market-based risk. Because in many programs, there's kind of an expectation that services will be provided and then the funding for those services is not guaranteed or can be taken away. And I think that's a challenge that we've had over time. We want to make significant investments, and particularly in a program where the underlying fee-for-service rates are barely kind of covering, I think, costs. So if we're envisioning asking groups to do things and there's funding tied to that, there needs to be at least some of that funding that is quote unquote guaranteed to allow organizations to make that long-term investment in those services. Because what we've seen, if that's absent, is that organizations cannot make those long-term investments, and then we get programs that are basically don't achieve outcomes. And then I think there's a portion of it that is tied to outcomes, that is tied to performance, that is perfectly appropriate to have on top of that. And I think just something to think about as we design a model going forward.
I'm glad you said that, Joe, because I was going to say the exact same thing. I think the fee schedule does have to change over time, right? Because the cost of living goes up, the cost of employing them. So I think the separation of the base and the performance base is really critical in any model going forward. Because we can't hold fee schedules flat because the cost of providing care is going up. There's no dispute about that. I think to Ellen's point, there has to be a strong value proposition included. And I think that's what you're trying to get to with quality is one of those aspects of total cost of care, affordability, utilization metrics, and access. And I think those are the sort of foundational elements of what we should be rewarding, but we cannot underpay the providers because they won't be there to provide the access. What I always worry about is people are, because we deal with this, right, a lot with pediatricians, there aren't that many specialists that aren't willing to accept Medicaid. And so I always worry that we're going to be in a situation where we can't do these kinds of models anymore because no one's willing to accept Medicaid.
I think maybe we'll
Break schedule.
we have a break schedule. We'll take it and then come back and keep the conversations. We'll try to
I already have that.
10:50 we'll be back, so it's 13 minutes, a little over the minute break. Sound good? All right. Sounds good. See you all in 10:50.
One of three, you're one of
I know, he was points for us.
Thanks for sticking with us.
Even like the other two.
All right, we're starting.
All right, sorry.
Excited to be back.
Jay, we just gotta get, there could be employees.
You'll get there, you'll get there.
Design element. So, for the next part, just wanted to, we've already had a pretty robust conversation along the way. And what we're kind of framing here is really like, what are the next components of that need to be, and we've already said, there's a lot that has to be decided and discussed. And so what you'll see is we just tried to map out what some of the pieces are. And I don't think we need to go into extreme detail and probably just open up for more conversation. We actually don't have that many slides left. But just wanting to say, like, what are these design elements? And we've already said there's some really important ones that we need to talk about. If we're talking about a hybrid payment, what's included if there is a PMPM, what actually would be that breakdown? And I think Mark's point is very well taken. If we're talking about shared savings, shared risk, what's included in that pool? Is it a total cost of care model? Is it a very small portion of some dollars that we're considering? So I think just to name, there's a lot of decisions that have a huge impact on the program that need to be decided still. So I'm just going to kind of walk through them relatively quickly and then open up, because my guess is going to generate a lot of further conversation that we've already had a robust one. So cross-cutting features, these are just kind of features that are really important regardless of how many tiers or tracks you have. Are what's the population? What's the member attribution method? We've already talked a bit about that. The risk adjustment methodology, and we've discussed like the importance of it considering both clinical and social risk. And again, what you'll notice here is, I'm not going to go through it extensively, is on the right-hand side, we did try to say initial approach, but then what's the principle that ties back to based off of the conversations we've had to date. And so I think, again, not to belabor, I think we can more quickly walk through these and get some more conversation, but the next slide really gets us to what's this portion of it. And I think, Mark, to your point, like, what are we solving for here? And kind of recognizing that there's a lot that needs to go into the discussion on services would be included, what's still fee for service, what's the best model that really services like what's the basis for this framework. But then I think going back a little bit to Alice's point about the incorporation of BH services and kind of the need to maintain, probably as of now, a fee for service basis to promote that access. The percent of revenue transitioned, again, back to that point of what is included. How do we define that? There's a lot that has to go into these conversations. Like, is it percent of revenue? What actual codes go into this or services are included? And then thinking about the billing process. If we retain a primary fee for service billing, that does obviously make it easier for providers because they are very familiar with this, with how to do this. And it can cause minimal disruption if we're still having a fee for service base to this. And then thinking about prospective versus retrospective. So implementing, if we are a component of the PMPM as a prospective payment, provides some predictability and flexibility, whether that's a portion of the flexible funds or a portion of the base payment. Those are, again, they serve kind of a similar flexibility, predictability portion. The next slide goes into that flexible funds, again, different from the term Alice had used, but there's a constraint here just flagging as we discussed. We talked about how we're paying and then how much, and this obviously goes into how much dollars are appropriated in terms of that value. But thinking about what's the dollar amount or the PMPM that goes for additional funding that otherwise underfunded services for. And then thinking about, again, timingly perspective, retrospective, perspective being upfront, retrospective being afterwards. Again, thinking that based on our conversations to date, that prospective payment really provides that predictability as we discussed, similar to in the base payment. On the next slide, you'll see we go a little bit more into the quality performance and having that performance measure slate being really, really important. I'll just highlight that we know that this is really important for getting the right measures to drive towards what success and those goals, but also knowing that multi-payer alignments there's the tension here, and knowing that there's an OHS quality slate, but that Medicaid members may need some other measures to really drive us towards what we think of success. Thinking about performance standards and scoring, so having that methodology that helps us drive towards those goals, and how do we hold providers accountable in that, including on quality, equity, and access, and also recognizing that both performance, so how providers perform relative to others, as well as improvement, are important to recognize as we build this out. And then thinking about, again, the value of the P4P in application. So again, the constraint of, is there additional dollars available? I think Polly, your point is well taken, that obviously how much are you actually able to generate will be really dependent upon how many dollars are available for this program. But just of note that that value helps create those incentives to actually drive change, and it's a really important piece. The next one is the quality gated shared savings, shared risk. So again, back to the what services are included at the top in the shared savings shared risk model. You have to define what's included, what's not. It can be very large. Total cost of care, it can be much smaller. And then obviously providers accountable for that. Can be a way of incentivizing and potentially rewarding a focus on prevention and management. The quality measure slate, similar to the last one, really, again, important to make sure that there is some multi-payer alignment, also recognizing the needs of Medicaid members and the need to drive towards what we've defined as success here are important. So there's going to be a balance. Setting performance standards, scoring and application. So again, similar to last is really setting those standards, scoring methodology, and how do we do it in a way that actually drives down disparities. And then again, this came up, I think, to the point that was made about the cost benchmarking, and Jim, to your point, and the target setting methodology. An important part of how we do this has a huge impact on providers' willingness to participate and their interest in engaging, if it's understandable, and also if we're able to adjust in a way that seems fair. And then talking about the shared savings, shared risk parameters, recognizing that different providers are in different starting points with tiers and tracks. And then thinking about what those parameters are, as well as for mitigating unforeseen risks or risks that we do foresee because of the downside of potential underservice that may be incentivized through these programs. So that kind of summarizes the kind of key design elements that we think about next, and then we're ready for further conversation. And I see, Angela, your hand was up, so.
Just for the record and for my continual education on this, can you just vocalize one more time why we continue to exclude the Medicare, Medicaid dual? I need to wrap my brain around that, and how those providers that care for that geriatric population are included in these models moving forward.
It's a really good question. I think there's a desire to try to figure out a way of incorporating them effectively. And there was some work Bill Halsley was helping lead on in the last decade ago to try to help think about how do we incorporate duals. And there's a desire in PCMH Plus to actually include them. But one of the biggest challenges, and just to take a step back, is like, well, dual eligible members are dually eligible for Medicare and Medicaid. And our integration of data systems and billing are, I would say, not seamless in the least. And so it creates a lot of challenges when you have pretty much two individual payers. We're kind of paying for crossover claims. So if someone goes and sees someone who's dual eligible, so that Medicare and Medicaid, say they come see me as a primary care provider, and I'm in a private practice, they for Medicare, right, there's a 20% co-payment that they're responsible for. Medicaid's gonna pick up as a crossover, that co-payment as a crossover claim. And Nina, I think you might be on, feel free to get anything I'm wrong, because she's gonna be more expert than I am or anyone else, but it becomes challenging because we don't have integrated data systems with the Medicare information. And so we know a lot. If you're just on Medicaid, we have pretty much the full system that we need. I mean, there's more data we've talked about that we need, including access to EMR data, but in terms of claims and other things, we see the full picture. For Medicare, we're only getting a slice of it for the most part. It makes it really hard to operate a program when you don't have a full understanding. I think there's ways of doing it, and you may want to add some more to this. I think there's a desire to include them in a meaningful, people who are dually eligible in a meaningful way, but there's just a lot of barriers for us doing it kind of right now. Not to say we don't want to. You want to?
Angela, I really appreciate the question. Everything Brad said is true. Maybe I would also add, for members who are dually eligible for Medicare and Medicaid, we Medicaid are not the primary payer for primary care. Medicare pays first, and as Brad was saying, we pick up the pieces subject to some rules that Medicare doesn't cover. So the proposed exclusion is just recognizing the fact that this group is on primary care reform, primary care payment reform, and we don't have we don't have someone from Medicare in this room, and they're the 300-pound gorilla, and Medicaid for those members is kind of around the pieces. Let me leave it there. We'll say there are models that some states have done for better integrating incentives and data between Medicare and Medicaid members, and I think those are worth pursuing. But I think it's a sufficiently, in my humble opinion, please push back, feedback, welcome. It's a sufficiently different topic from straight Medicaid members where we're the primary payer, and I think that's the main reason there.
So as a follow-up, what measures are in place to look at that population health quality improvement for that population? Are we just don't care? Like, what are we doing to track that?
Part of MSSP.
They're either in our Medicare Advantage contracts, in our MSSP, they're kind of noted as dual eligible. So we would be accountable to them through Medicare as the primary payer. But they are noted as such.
So for example, if Medicare's reporting readmission rates, hospital readmission rates, dual eligibles are included in those reports of readmission rates, surgical site infections, and access to.
So Medicare's tracking it, but are you tracking it as well? Is anybody paying attention to it, I guess? That has the
State level.
at the state level.
That quality.
Yeah.
Medicare publicly reports most of that quality data.
But are we paying attention to it? It's reported. Does it sit on a shelf or are we actually engaged with moving the needle towards improvement? Is anybody watching is my question.
I think Medicare is watching because it contracts with local providers like Northeast Medical Group or CMG to manage that population under this MSSP or Medicare Advantage. It's called a special needs plan. I don't think anyone at this, I shouldn't speak on behalf of the state, but I don't think anyone at the state is managing it except the provider groups that are contracted with Medicare to do exactly what you're saying.
Right. And so every plan like Aetna's Medicare Advantage, the stars ratings, the duals are included in that, and that's how CMS is managing the population.
CMS is manager, but is anyone
the
at the
payer.
state level paying attention to the outcomes?
I will say we
Are
have,
these
you have
folks on an island of their own?
So I think generally there's a big challenge for people who are dually eligible, that is recognized, I think, relatively nationally, that the integration between Medicare and Medicaid often leaves much to be desired. Partially because like when we try to look at data for dually eligible, we have actually limited insight into what's going on because we're only getting a partial access to the data, and we actually have a contract to get more access to Medicare data, but it actually excludes some challenges with getting Medicare. So there's traditional fee for service and there's Medicare Advantage, and getting access to both of the data sets. So it's something that we are interested in, but are even challenged by as a state to have full access to the data we have for just Medicaid. So say you have a bucket of information for Medicaid members, that's like, say it's a full bucket. For Medicare, our bucket's a lot smaller, so it's really hard for us to even know how the members are being cared for in the same way.
Last follow-up. So at the state level, is there any desire to get some kind of qualitative analysis of this population to check in as to how things are going?
Yes.
From from community health workers, organizations, anything, so that you know that these citizens who have probably lived here, worked here all of their lives are being cared for appropriately in their latter days.
I mean, I'd be curious because we do not get Medicaid claims. If we were able to even, if we're able to see anything different, if we were able to join our Medicaid claims with our Medicare MSSP claims, and MA claims data to get a better picture of their total experience. My hunch is we would, but I've not gotten our Medicaid data to know if I can do that or not. And I think there's also potentially, because of the programmatic design differences, yes, Medicare is primary, but there are things for which Medicaid functionally is primary because Medicaid does not pay for them at all. Primary example, which is very expensive. So you could,
example,
long-term care,
Nursing home.
things like that, Medicare does not cover. So there could be things that are Medicaid primary that might be worth us taking a look at as a way to kind of, look at alternatives.
Yeah, I really appreciate the push. It's something to say keeps me up at night is too strong a word, but it's something that I really think a ton about, because I do think primary care, for example, you brought up long-term care, which is a great example. Primary care can influence whether a person needs long-term care.
Yeah.
And long-term care is very expensive. And it's also, you know, most people want to live independently on their own. So I'm not saying there's not a connection, just because Medicaid is not the primary payer for primary care, our tools are very, very limited for what we, the state, can do for dual eligibles. Because because it's mostly Medicare in this portion of their care. But Angela, sorry, I didn't mean to cut you off.
So and I'm sorry for prolonging this
No.
line of questioning, but in-home, folks wanting to age in place and stay at home.
Yep.
Medicaid can cover
Yep.
someone to come in
Yep.
and check in, you know, a few hours a week, few hours a day, or whatever. That's major and can totally improve the quality of life
Yep.
for folk. And check in to see if they're still eligible and is it a good idea for them to continue to live independently? So that's, to me, just makes sense if we're trying to take care of the citizens of the state to be monitoring that.
I could not agree more. I think the transition to home-based services and what Medicaid covers and how that can be a bridge to, you know, keeping people out of facility-based care is really, really critical. I have a daughter who's the Medicaid waiver in the state of New York, and we get in-home care for my daughter, and she's out, not in a facility. And I wouldn't be able to do it without Medicaid. So but all of the savings of not being in an institution accrue to my primary payer, which is a commercial product. So Medicaid is secondary for my daughter. But that's just our own personal example of that.
It's not like they're not being managed because they're attributed to these adult providers under the MSSP program. So just like we're talking about the value-based program, the MSSP program is Medicare's value-based program, and they have 4 buckets of individuals, which I'll be pushing myself to remember, but one is dual eligible, one is age disabled, one's age non-disabled, and there's one other that I was.
Stage renal.
And stage renal disease, yeah.
So it's not like they're not getting care management or care coordination, it's just not under the auspices of the Medicaid value-based program.
Can I just, at MAPOC, I used to chair the complex care committee, co-chair. And under, Kate McAvoy, she lived and breathed, elderly healthcare. And there was a lot done at the time, and we did used to get those kinds of reports, and maybe it would be good to have another update and send it here to give people an idea of what we are doing around long-term services and supports and things to keep people out. And I remember being impressed that it was, there was no spaghetti falling off the wall. Kate was like, if you've got a good idea, we will try it. But I don't know what's happened to that. So maybe.
Yeah, I mean, something as simple as minimizing fall risk.
Yep.
If someone's coming in the house,
We spent months on.
you know how much damage is done just by one fall, and hospitalization utilization skyrockets just from a fall.
Yep.
That, to me, would just make common basic sense.
You should go to the care manager for the chronic
Let's
conditions.
connect offline because we do make claims available to the PCMH plus PEs. I don't see that there's a barrier to any PCMH practice, which. North is-
Great.
I just would implore that if we take the blinders off and just like take away the tunnel vision, looking at something how we've always done it, like, can we open the blinders?
I guess I also wonder if there's, you know, we spent a lot of time talking about where's the money gonna come from? And I don't know how expensive all of those things are for the Medicaid budget, and if we did it differently, would it, you know, create other avenues to invest in other services?
That's what I'm remembering is that, because we ask those questions at MAPOC, because every dollar you're spending here, you can't spend somewhere else. And I have a vague recollection that we were hearing that it did make a difference and there was good evidence around it. There's a UMass group that did an evaluation, if I remember. So yeah, look in the file drawer. I'm sure it's there, or we can call Kate. I'm sure she'd be thrilled.
Talk to Kate Freebrand. Or tomorrow.
And I think, and just as your point, like, that we definitely care, that we know the population is really, really important, and also is a really high risk population often. Some of it's like, what can we do and what resources do we have to have an impact on that, and how much, what's the lift to actually to try to bring them into something like this. And I would say it's probably a pretty significant lift, not that it's not important to do. And so I think it's something we can kind of bring back and figure out like what would be the lift. But it is not insignificant, having looked at also when I had started initially. There's just a lot of barriers to doing it effectively, but doesn't mean we shouldn't be trying.
Mhm. And I would be remiss if I didn't add, having a CHW in the home can also allow for them to make a referral to, say, like a Rebuilding Together, or for someone that can come in and put in accommodations, handle grip bars and different things like that, which left alone, sight unseen, you only go to the doctor's office, no one sees that, right? So just those
But I will-
in-home evaluations.
Yeah, I will say though, like our population health infrastructure that is funded through, you know, some of the Medicare programs, whether it's MSSP or our MA programs, we would make that available to those DSNP, you know, populations too. So our CHWs are servicing our Medicare members as well as our Medicaid members. But I totally agree, getting the CHWs out into the home for those kind of things, for this population in particular, is really valuable.
Aren't there like home healthcare aides
Need a
too?
break from facilitating?
I'm sorry, I jumped in, I
Over to Alex.
apologize.
Please.
There are home healthcare aides who do cleaning and things like that. I'm not really sure how and what, you know, where they're paid for, but could be trained to look at safety issues and play a part in that.
Let me give Brad a break from facilitating and also let him be, not that he's already both contribute and facilitate, but maybe a little break. I don't see any other hands on this topic, so I just want to kind of take it back to some of the key design elements. If folks have comments about that, but I might kick off just circling back to a conversation we had earlier around the PM/PM / fee for service integration piece, because I think that's where we started. And I'll pose the question to the group. I think there was concept that this might be we may not have heard the feedback correctly, but to put out for discussion, is there an openness to potentially having that part of a glide path or a selection? I think there's an option, you know, a comment earlier about let practices select where they go in. So I just want to put that back on the table before we kind of take this feedback and incorporate it into the next version of the design.
So I just had a question. When I looked at the framework, it seemed like basically, what do we call it, small and large, or A and B, the only difference that we're thinking about is around whether it's a performance or a shared savings model. That's really the only difference between the two tracks. Is that right?
Yeah, would you mind putting this back up to Thor?
And to say, I think a lot of the detail on this has to be refined. So even that first base payment, as we discussed, like there's a lot that goes in that in terms of, and also noting there's multiple potential tracks. And I think, Ben, to your point, like you said, could it just be A and B instead of size? And I think we should definitely, that's probably worth discussing, but just to say like this is meant as a very high level overview framework, as opposed to like, this is the detailed thing that you're gonna do starting tomorrow.
Yeah. I think, I don't know that I have a lot more to add beyond the conversation that we've already had about it. I'm sure I'll have other things once the conversation gets going. But I do think that I wonder whether there are other distinctions that we might want to make between the tracks beyond just the quality performance P for P or the shared savings risk. If we're just thinking like high level structural design.
Yeah, and I think there is a bunch, maybe in, I'm not sure which slide. But to say yes, there will need to be a lot of distinction or a lot more discussion. Again, this is kind of like, here's your very amorphous, like high level, and then getting into, okay, well, if we have small provider track A versus small provider track B, what are the key distinguishing features of it? Because you wouldn't want, they wouldn't be the same. They wouldn't make sense, right? You wouldn't have an A and B that are exactly the same. You need to have very distinct differences between them, and it could be on questions of like, okay, well, maybe, or again, I'm not suggesting this is what we do, but A is like a purely fee for service base, B has a portion of it that's like a PMPM, or, I think these are the kind of distinguishing features that we need to discuss in detail to iron out, like, okay, well, what are the options and what makes sense for how we would roll this out?
And so if we're not thinking about it in terms of small versus large, but we're thinking about it as two high-level tracks that might have some distinguishing characteristics within them. What are the differences between those two tracks, or whether that has to do with the goals or the risk? Is it about like, you see what I'm saying? Like if the distinction isn't big ones get to do this or have to do this, and small ones get to do this or have to do this. So is the difference really just about how much risk one track is taking versus another?
So I think that could be part of the conversation, but it also includes like, what are we asking? So if you look at, say, Massachusetts, for example, they have different requirements and different tracks, and actually, they can get additional dollars for meeting certain requirements. So having, Olivia, probably the.
Yeah, I mean, I guess the clarification maybe that I would offer in terms of the size, because I think that's out, and it's the rightful one, is I think the small and large provider track basically recognizes, right, some of the limitations that small providers will have in terms of participating in certain, right, quality performance-based shared savings, right? So your point, like sort of earlier, right? Like if I'm a small provider, an outlier case is going to have a much bigger impact on me. And so I think there's a way in which, right, maybe the sort of size distinction here is coming through most strongly, but to get to, right, the sort of capabilities kind of tiering right to the Mass Health point, where you have, 3 tiers that you could imagine sort of being within this, or being perhaps the more prominent sort of tiering distinction, right? That say, okay, I have a tier 1, I have a tier 2, I have a tier 3. There's a different care delivery expectation right across that. I get paid a different PMPM that gets incrementally higher across those 3 tiers because I have a different level of expectation, right, around what I'm doing. And so as I potentially, move up or don't move up, right, sort of required graduation across those tiers and do more as a provider, or expected to do more, I get paid more, I have more performance incentive opportunity, right? So I have both a higher PMPM and a potential to earn a greater bonus payment. And then there's the complication of the ACO structure, so you wouldn't have necessarily the same kind of quality gated shared savings at the practice level. That kind of capabilities tiering, right, that I think we're hearing from this group, is coming through as a sort of potential add-on here, but I think the size distinction really is almost definitional, right? It's not to say you wouldn't have a capabilities tiering. It's just to acknowledge, like, when we're down here in this green area, it's small providers, right, can't to some extent, depending on their size.
Size attribution, right?
Size attribution.
So it feels like there's you guys were right to say that there's all of these dimensions that we need to define, right? And just from a problem solving standpoint, we need to start putting some stakes in the ground about how we define things. And so otherwise you're trying to define like everything all at the same time, which is an impossible problem solving task. So it feels like there's one track that has some sort of pay for cost performance or some sort of shared savings component. And you're right, we had to define what are all of those things, and then there's another that's not based on that, that's based on achievement of certain quality outcomes. Is that a fair way to put it? That we're gonna try to create at least two different tracks, some of which will take on a level of financial risk and some of which won't.
I think, and I just want to say in terms of that shared savings, shared risk, like we're not even defining like there's definitely one versus the other. It's just saying these are options where we're starting place in terms of keeping on the table for those further discussions. So, but I think you're right in terms of breaking it down as a performance, as a shared savings or shared risk, depending on where those conversations go. You know, those are reasonable kind of pieces. Now we still have to define what's a small provider and what's a large provider. So just to say, there's even definitional pieces within that we need to do.
But I'm gonna push back and say, I don't think you need to define it based on the provider size at all. If you're giving practices the ability to choose the track that they want to go into, up to them whether or not they feel like they're ready to take on or have a desire to take on a level of financial risk, or they don't, regardless of whether they're big or they're small. That's
Actuarial considerations notwithstanding, because if you're too small.
sure, but again, the provider should have. You might want to be a little bit big brother and not let someone choose something that's going to be very risky for them. But those like a provider, because you don't want to create a situation where a provider is really failing, that's not good for the care delivery system.
So Paula, you've had your hand up for a while, so I know you might. I know there's gonna be reactions to that, but why don't you go and then we can.
Sure, I guess, when we're looking at, I want to revisit kind of one of the things where we started from was in today's world, there's, I think like 4 different options. You can do nothing, right? And you cannot accept Medicaid insurance as a primary care provider. You can complete an attestation process that gets you on a list as accepting Medicaid, and you get a bit of a bump. You can go through a PCMH certification process and be in PCMH, and then not lately, because it's been closed, you could have also applied and gone through an RFP process to get to PCMH Plus. So in today's environment, there are 4 different things. Are we saying that like there is like, if we look across all those 4 things, that we're consolidating those into kind of a fundamentals, like a Medicaid fundamentals, and you've got to do this, this, and this, and then you're in the base track or whatever we want to call it, and then there's more advanced options from there. So I just want to make sure we're not thinking PCMH and PCMH Plus, but how does this wrap around what exists, those other kind of 2 avenues, if we also want to get more providers into the program?
And to Ben's point, maybe practice size doesn't matter within a certain range, but if, Polly, you just spoke to our 4 practice settings perfectly with no education on it, so you figured it out on your own.
No, I think it's been pretty educated. You managed it.
Practices into PCMH, and we are definitely at that point where the practices are like, it's not worth my while. And when we look at their attribution, they're all under 100 Medicaid members. We have some that are, and why? Because they're PCMH for other reasons. So why not take advantage of it for those 100 members? But just to become a PCMH for 100, so there is sort of this inherent break point where it's just not, it doesn't make any business sense for the practice to undertake that.
Can I get back to my Google? It sounded like you, I'm sorry, I'm stuck in the line. There's a lot.
You had your hand up, then you took it down, so.
No.
Just go ahead.
Alice is on mine too.
You said there was a consensus around a fee-for-service, a merged fee-for-service with per member per month.
No, sorry, I misspoke. That's right.
Because there is no
Definitely not.
consensus if you're talking about the base pay.
Yeah, no.
That is not, I vote no. And my understanding of consensus is it's unanimous. No. There's no right way to do the wrong thing. We can talk a lot about big versus small, but I really feel that there has to be a piece of it that is not provider risk. And you're laying out an option where every single part of everything that provider risk, and that is scary to me, for consumers.
Not sure, you mean in terms of that small track, is that what you're saying?
No, for the large track, it could be all per member per month on every single bill. Well, I guess shared savings is a different, it's not per member per month, but it's shared savings, it's all provider risk. Yeah, it's all.
To clarify my question, I guess what I was saying was, what I heard was that it was disfavored to have the PMPM within the base payment.
Oh, then
That's what
yeah,
I heard. What I
Correct.
asked was whether there's openness to considering PMPM as part of a tracking system
no,
within the base payment.
no consensus. No.
Base payment.
Within
Explain that,
the,
I'm not sure I understand that.
So essentially you would have, like, if you have tracks, you can have different tracks within those. So, for example, in Colorado.
With the slide back up.
Yeah, Colorado could be an example, or another where you have you can have tiers of people who say, let's just say tier one is just straight fee for service, and there's a P for P. So basically our existing P for P program, or PMH program. You can have a tier two or track two that says, actually, we're going to take a portion of, and we have to define obviously what that PMPM is as part of our base payment. For a defined set of services, we are interested in taking that as a population-based or PMPM. There's still some portion of it that's fee for service. You could have a track three that's like, no, we want all of it. I'm not saying this is what we do. I'm just saying this is how you could think about it, where you have different tracks within that, and different portions of that is laid out in different ways. So, does that help?
I understand now.
I think Alice was.
Hi, thank you. I'm so sorry I'm not in the room. You know, the shoe doesn't fit, then don't wear it, right? And this is what I feel like. We are talking a lot about primary care docs kind of doing this more social determinant work, or, you know, partnering or whatever. What if we used, because what we're doing in Inc. is we've created through targeted case management, a per member per month rate on the tier level of need for the family, the individual youth. What we've been able to do is actually enroll at least 4, if not 6 now, private providers who don't normally bill Medicaid, and they're able to work with the individuals and the families to be able to create a needs conversation, well, to review the needs conversation and actually work with them to address their needs so that they feel more stable, more empowered, and more closely feeling like they have someone to go to if they have you know, particular need. So what I'm saying is, instead of using the PMPM for the primary care workforce, actually develop a new, really firm workforce that Polly's building at Yale and other people are building on, you know, community health workers, care coordinators, and use those dollars to build that workforce. Then you can have contracts with primary care. Primary care can identify and refer, and they can get whatever, you know, dollars that they might need to be able to work closely on that integrated holistic team. But that there's this group in Connecticut that is raring to go and you know, deliver this kind of care for individuals that goes well beyond, you know, healthy food and other things, to look at all of the nuanced needs that a lot of our families struggle with, that are not barriers. You don't even imagine what the barriers are that impact families. So, you know, I guess what I'm saying is let's just, you know, take it out of primary care, put the money, which is what we're intending to prove with Inc., and, you know, have been able to get to a pretty decent point on, and, you know, have a workforce that does that and works in collaboration. You know, we're doing it with primary care, but we're also doing it with schools. So anyway, I feel like the docs are not going to be able to build that. They don't have the time. The money is insignificant. And, you know, yet there is the possibility of doing it from an economical perspective. And, you know, anyway, that's what I think. Thanks.
So we have 100% captured that. If you're in the room, I think there's a sense that we want to just circle back on the previous piece of the conversation. So thank you, Alice. I don't know if it was Mark and then Guy, you wanted to say something? Yeah. go ahead.
Did you want to respond?
My comment was not in response to Alice's thought.
So, the thing that's puzzling to me at this moment in time is that I know there's, everyone's paying great respect to the wish to have guardrails on this conversation and to ensure that we're talking about a primary care reform. And, he made references to parallel tracks, but in some ways, I don't think you can really, you can treat them in silos. So if the AHEAD model application is successful, which I fully expect it will be, and May you'll be the beneficiary of an application. And the global budgets that are contemplated there would also have a total cost of care up and downside risk model where hospitals would share in savings or have downside risk. And so that's sort of one, and there's a primary care component to that, right? So this idea, so these tracks and the options have a great deal to do with whether the state moves forward with AHEAD and who participates in it. There's also, as we've introduced in January, the hospitals have surfaced a framework for Medicaid planning, and we've talked about this in this group, which is a methodology that would allow all practices, regardless of size, to participate in shared savings through a regional accountability model that focuses on rewarding collective success and solving for both primary care access and quality problems, but also in the surrounding areas. A shared arrangement where, as we talked about earlier, would have a role for hospitals and community partners and that sort of thing. And so it feels as though we have that conversation about this idea of a regional accountability model that would enable a small practice to aggressively pursue success and be rewarded for its contribution, for its population within the context of some other design. And I don't know how to bridge that. It's almost like, how far can you go with this conversation if we're not having the other conversation about a range of possibilities that where the path hasn't been laid for the past 10 years? Because there is a certain playbook and elaborations on that playbook, primary care attribution and total cost of care accountability. And we're in a new era where we're looking now 10 years ahead. And the question is, are we short shrifting our thinking around primary care by not thinking about how, if it was embedded in a more comprehensive solution that included community partners and hospitals, it actually might open up some different possibilities for primary care. But I just don't see the, like, how can we advance this conversation in a way that isn't inherently limited because it's pretending, it's sort of ignoring the AHEAD conversation or other conversations that might be elaborations on AHEAD or alternatives to AHEAD that could, you know, that frankly need to be a part of DSS's planning per the statute 23-171. So the commissioners talked about that. We've got to have a plan that's more comprehensive, that looks at root cause risk and all that other stuff. So that's sort of the dilemma I find myself in at this juncture is we're talking about these sort of finer points of architecting options without considering how a more comprehensive strategy that's more systemic in nature might actually create new and better avenues for making an impact and for primary care.
I don't know if anyone has, I know you've had your hand up for a while, Joe, but did you want to just weigh in and then we can kind of circle back to that?
My comment's probably somewhat in
line with that? Okay.
Yeah, so here's my take on it. Mark's comments are well appreciated. We've been meeting now for close to a year. And I have a little sense of kind of the old saying, making perfect the enemy of the good in this model. And I think that we've been talking about large comprehensive models for a very long time, many, many years. And although I think that we should continue to do that, we continue to strive for that. They are hard to do, they're complex, they're by no means guaranteed to come to fruition. And I think the work that we were tasked to do has a clear focus, has a narrower scope, but it is certainly one that is needed, one that is supported by a plethora of other similar programs and other payment models. Also, the reality is we have a model right now in this population that is stagnant and needs to be fixed. Like, we cannot continue to have a model where we keep turning out the same program without opening it up to other organizations in the state. It just makes no sense to do that. So I think there's an urgency that we need to do something, and doing something in this case has valuable, I think, contributions to the process going forward, because it aligns our groups together. It focuses their concentration on the Medicaid population. As these other conversations continue to proceed, there's nothing that we're doing now that is exclusive of what those things are. And they're not going to be available in the same timeline. And when they come, we'll have been better served because we've engaged our populations, we've engaged our provider groups in a way that supports that process going forward. So I would strongly encourage us to be a little more focused, a little more streamlined on the specific task at hand, which needs to be addressed. And there's ample opportunity to do that, be successful. It's not exclusive to anything anybody else is mentioning here. Second point I'll make is that, and then also within that context, I think simplicity is better. There's a lot of complexity that I think that's been raised today. And I think that given the scope of time and looking across programs, the ones that have been successful and the ones that have caused the least kind of, I think, retrospective, we should have done things differently, are the ones that have said, let's start simple. Let's think about a glide path. And this glide path, though, really should be over a longer period of time. And how do we implement things? Honestly, just implementing a program to begin with is complex and hard. And so implementing a simpler program is inherently going to be easier and less fraught with other areas that we participate. And so I think that there's a simple kind of scope to this that could be laid out, that could be done, and then have a multi-year glide path going forward. Final point I want to raise is there's some more of a rhetoric issue is we keep referring to this PMPM concept, and I think it's conflating two different terms. There's a traditional care coordination fee, PMPM payment that we think about, and then there's a capitated payment. I'll use that term just, so I think we should disconnect those two terms because it's confusing, and we should kind of clarify what we're talking about, because if we put this out there, some of us are thinking capitated payment to PMPM, and some are thinking more care coordination fee. And once we get it out, folks will understand the difference. So that's my.
Yeah, thank you. I'm debating, I'm also looking at the clock, and I want to make sure we have time for next steps. There are a lot of good things. I'm not responding point by point. Just maybe a couple quick points on the issue of tracks and choice. We heard loud and clear from providers, more choice is good and recognizes the different size, the different capabilities. That all makes sense. To the Moneyball comment, I'll just say the tension that we have is there's evidence that the more choices you give providers, there is a degree of moneyballing where providers who are going to win, even if they don't change their behavior, can shop between the tracks and do better. So we're just calling out the tension there. I think choice is really important. Participation is really important. Obviously, if Medicaid has too many requirements, a lot of providers are going to walk away, and that doesn't serve access, which is one of our key goals. I will just say if we have too much scope for shopping, that can blow up the budget, and if we end up spending dollars on, there are fewer dollars to spend on other things. There's just a small comment. On maybe the bigger picture on the CMS ahead model, et cetera, I think it's a really good question, Mark. I think I largely agree with Joe that I don't think a majority of Medicaid lives, even if Connecticut wins ahead and if we move forward, I think it's going to be a robust minority of Medicaid lives that are in ahead. And I do think if we go down that path, we'll want to think really carefully about how this program intersects with that. And I think that's definitely worth calling out. But I think the vast majority of Medicaid lives will probably not be in ahead. So I think I view this group is kind of focusing on that big slice, not entirety, but the big slice of the pie. A lot of other good comments. I'm not going to respond to everything. I'm listening, and mostly I'm here to listen.
Jim, I'm just gonna, Joe, I went where you and I completely support. I think that given the uncertainty, whether a head comes forward or not, there's going to be a whole lot of things. And bringing back simplicity to a model that really incentivizes the foundational build that needs to happen would be the clearest sort of path forward. The more complex we make it, choices make it, because I think there are some core things that, as you said, need to fix the current model that really would be a good investment in primary care, which would support everything else that's sort of coming our way. And so I think that that's really just a wise, we can continue to think about this forever, but if we can get down to what are those core things that we're trying to do, incentivize them and make them readily available if you perform well, would resonate.
I think in light of all of the constraints that you've talked about,
Yeah, sorry. I feel like I'm the Debbie Downer of this conversation today.
talked about all for this population.
Yeah.
This is a Medicaid population, it's not a Medicare population. What drives excess costs and unnecessary utilization and fees burden for a Medicaid population is a lot of things that are outside of primary care and outside of the medical system. And so in a world where we're recognizing the constraints and we're saying there's only so many dollars that we have to play with, and we're not going to think about larger systemic transformation, and this is going to be something that sits outside of the AHEAD model but needs to make sure it interdigitates. We need to be realistic about what we can expect out of the primary care practices, especially if we're going to be thinking about cost of care. Because if our providers aren't able to get their patients connected to social services because those social services are underpaid, if they're not, and we're not addressing that at all, we're not able to think about that, and we're saying there's a whole bunch of constraints around that, then we're really limiting our ability to move the dial there. And so when we move into the conversation about some of the design elements around what goes into a shared savings model, like all of those things, we will need to be very mindful of the fact that there's really a whole world of things that they don't touch that we're not changing. I guess is what I would say.
Realistically, from a time frame perspective, it's feasible to have this in place for 1/1/2025.
No, definitely not.
I was gonna say, it feels like we need to do some backing into when certain steps need to happen, but it doesn't sound like that's the case.
No, definitely not. That would be not practical. Impossible. 1/1/25 would be, it's not.
I'm not a clinician. I fully recognize that the rules and incentives and programs that we create are only words on a piece of paper. What really matters is how members and providers experience it, and that takes time. And if we publish something on day one, it's not like practices can respond and do all the things that we in the room want them to do 10 days later. So yeah, January 1st, 2025 is definitely not.
PCMH plus ends at the end of 24, right? So is there like maybe it's not appropriate for this conversation, but I thought that this group was about deciding what's going to be in place in 2025. So I'm just curious about how those things don't come together or do come together.
Yeah, we need to do more thinking internally. I think we want to give a little bit of flexibility, and we need to resolve that soon for the previous comment, because I understand the providers need certainty. We want to give ourselves a little bit of flexibility. If, for example, we're here today and we decide we want to go there, we may want the glide path to start sooner rather than later. But we really need to tackle this. I hear you, and I'm on it.
It's like maybe 1 more minute, if there's any other final comments, and we'll talk about maybe next steps as a couple. Not, we can jump into that. So I think, talking about where we are, so it's really ending this kind of overarching program design phase, and then trying to move really into, as we've discussed today, a lot of the really important pieces of this, in the technical design phase, which is very complicated. And I'll just note all of the things that we outlined, those really have to be answered, and a lot of those build off of each other. And to your point that you had raised, like, it's often build over time, and so some of these core discussions, and Angela, to your point, like what population is included, I think there'd be a lot of challenges with trying to build in duals to this process. It would probably extend it or be a completely separate work stream, but it's obviously really important to consider. These are really important people of our community, of the state, recognizing there's going to be limitations to what we can do. So some of these early decisions have huge implications for the next steps. But what we're proposing basically is really having on the next slide, you'll see a subcommittee of this group, a really technical design subcommittee, to meet monthly, really focus on some of these really important technical design decisions, and thinking about what should these decisions be. And so we're really looking to really identify people who have some expertise and understanding of these, but report back to this full group quarterly. So really trying to have these more intensive meetings where we're really getting into the details, but bring it back to the larger group on a quarterly basis. So basically monthly intensive meetings for a subgroup, and then bring it back. I think, Polly, to your point, we don't want to have to reinvent the wheel. There's a lot of investment from this group. There's a lot of knowledge in this group, and we really want to tap into that and try to move this process forward, acknowledging that we also want to include those who maybe have less technical. Not sure what's going, sorry, we can't see you on the screen. It's still working. One of the monitors just reset. That should be fine. But just to say, we want to make sure we bring it back both to this larger group and also to, obviously, we'll continue to report out to our other, stakeholder, including care management, MAPOC care management, et cetera. So that's kind of what we're suggesting, and really starting these meetings pretty soon in a monthly cadence, recognizing like there's some internal decisions that we're going to have to talk about on the DSS side that will really come to fruition later this summer. So we'll be sending out more details to come kind of as we internally finalize it, but that's kind of our kind of planned or proposed next step here. So I wanted to pause and see, and I might need to help get this back up, but not sure what happened here. But any comments on this as I try to figure out why this is not coming?
Just maybe make a comment too, like, and I appreciate, the comment that, to get into the detailed design, you need, kind of subject matter experts in certain areas, but there are different domains of expertise. And so, individuals that really understand quality measures and all the different nuances of selecting and designing quality measures might be different than the folks that are building the financial modeling, and and then those things do kind of intersect. So I think I would just advise, like, there may be different flavors of technical expertise that are required at different parts of the journey. And just think about, how you're kind of creating that, technical subgroup or subgroups, to focus on, kind of a lane, and then to kind of bring that all together.
Can I just make one comment? Who you put on this technical design committee, because there's some big open questions still. And who you put on could make an assumption that we've already made a decision, and in fact, we haven't. And then you're like out of the gate and everything's already decided and you're just being annoying, Ellen. So I worry about, make sure that you're coming back to the committee or. I mean, I don't know if we vote. I don't know what happens if we get to a place where we're not sort of on the same page. That I think when you move it to a technical design subcommittee, that implies to me that, everybody's got an agreement on where we're going. And I'm not hearing that.
Yeah, and I think as part of this shift, we're kind of approaching this. We've tried to approach this initial phase 2 as very much like a open-ended questions, lots of discussion. And I think internally we've said, we really want to try to bring you so we kind of brought you a straw framework, which you responded to very, a very high level one today. And I think we anticipate doing more of that, where we're trying to have something that you can respond to more actively and then provide guidance to us along the way. So we're being more proactive. There's more us bringing you straw designs as opposed to more open-ended, nebulous conversations, if that helps define it a little bit more. So it's a bit of a switch from our current discussion, not that we won't be receiving feedback and, and hearing the critiques and other ideas, because we will be, but just trying to move this process forward.
I also just wanted to say, and Ellen, you did not say the following, so I want to be super clear, I'm not saying you did. I do not think at the end of this process, as much as we could talk about that, we're not going to leave with every single person on this group feeling good about all of it. I know that's not what you're saying, so I'm not.
No, that's what I'm saying.
That is not, I'm just being totally clear, that is not my goal. My goal is to listen, get input. You all have incredible expertise. I'm taking lots of, like, that is the goal. And then, you know, at the end of the day, TSS is gonna need to make decisions. Some of those, some folks will agree with, some of them won't. There will be a process, you know, yada, yada. And so I think in that kind of social contract also comes with my not being able to say, well, every person in this room agrees with the whole thing or all elements of it. That I want to lay out that I'm in the realm of the advisory committee, not I mean, ultimately, like, my boss is gonna make the decision of what DSS will propose, and then the legislature.
That was one of my conditions, to be honest, is that we don't all have to agree on
Yeah.
everything.
No, I know you're not saying that. I'm just I'm reiterating that implicit social contract on both sides that I feel like we're in.
And I think we're just we really want the input, and we may disagree and go, you know, but we think the input is really important.
Agree.
And I think that's how we really want to approach this.
For sure. I mean, the input is very valuable. We wouldn't be here if we didn't think it was.
I don't think, we won't be asking you to like sign off and be like, Ellen Andrews is in total agreement, because that. I think that would,
Happened in the past.
I don't, that is not the
I have a
process.
blog, so I can.
Just to say, that is not the, and I think we try to approach this on the maternity bundle a little bit, where we just we kind of had proposals and we got feedback and we refined it. And it was still the DSS, we had to make decisions, but we really used that to help make what I think a much better product at the end than we would have had if we didn't do that. Knowing that there's going to be disagreement.
Yeah, I'm just, can you put the timeline slide back up? I wasn't clear on kind of the overarching timeline through, okay.
We don't have an exact end date. We'd like to have, you know, this is a somewhat of an iterative process. As you can imagine, some of these build off of each other. So just to say, we will have to revisit this, similar to what we did this process. So we putting December 2024 plus, which means, you know, we can't launch in January 1 of 2025. But I think we'd like to move this forward in a reasonable way, but also recognizing that there's some give and take to this, depending on decisions and where we move. You know, I agree.
Yeah, I guess I would just be, you know, again, I don't know if it's anticipated like that this, like, we get to like whatever the start date is and like we're done, or if we would maybe consider this group kind of staying engaged post-implementation to consider if we're actually then seeing the results of what we've designed kind of coming through to fruition, and then providing, you know, continuous feedback on is, you know, where do we tweak along the way if it's not.
Want to express real openness. I mean, it's hard to look out like multiple
Sure.
years, but I think some version of what you said makes a ton of sense. And needless to say, we're not going to get it right the first time we try it. And I know there'll be room for improvement.
We've tried to do it with maternity bundle a little bit, which Mark's been somewhat involved in, we're not trying to say you've signed off on everything, but we've tried to, even though we finished our initial maternity bundle design. I think we had our last meeting in January-ish, if I'm not mistaken, where we still had some things that we're working on. We provided information, we got feedback on it, useful to us. And I anticipate us continue to engage in that type of, you know, maybe less frequent engagement, but still kind of checking in to say, hey, here's what we're thinking on the DSS side. What's the feedback from this advisory committee or council?
This waiver process different than like the state plan amendment process?
There's two kind of different, and we're not really saying which makes the most sense. I think we've generally steered a little bit more towards state plan amendments, a little simpler, but just to acknowledge that I don't think we're completely taking anything off the table at this point.
We don't really have a sense of how long that will take after we get to this point, right? They could take a month or a year, right?
Also depends on what's being proposed to a degree, and if it's something that's everyone else is doing in every other state versus doing something completely novel that, which I'm not saying we're suggesting in this framework, but there's obviously a lot of decisions that have to be made that some of these small decisions actually are big decisions by like CMS standpoint. So we'll be in touch. So we'll send out a kind of summary email and ask them what we set up with technical guidance. And I think your feedback will bring this out, we'll bring this back and have conversations. And I just want to say, everyone here and everyone's, we want to thank you very broadly for this. This is a significant amount of time that you spent here. I really hope this yields a really productive new step in primary care program. And I think heard a lot of your feedback. You really will be reflective on that. And we will, you want to invite you guys to share anything else or say anything else.
Yeah, wrap it up nice.
All right. Thanks, everybody. We really appreciate it.
Stop snowing at least.
I know.
Did it accumulate? No.
No.
There's a ton of snow up north.